It's activating right now.
It's streaming live, sir.
Hold on, it's still.
It's
Almost streaming live.
gaining bandwidth. It's one band at a time.
Preparing.
Yes.
I think that's a song. One band at a time.
There you go.
Okay, and it should be live.
We're good, sir. All yours.
Okay. I'd now like to call the September the 10th, 2020 Disciplinary Review Committee meeting of the Texas State Board of Dental Examiners to order. The time is now 9:06 a.m. If you're listening to this meeting on a secondary device, please mute that so we have no feedback. One device at a time is terrific. And I would ask you to state your name if we do any verbal voting so we can ensure a proper count. I will also announce your names when we're being addressed, and I can, since we're on video conference, I can see all of you, and if you have a comment, just sort of clearly raise your hand. Will probably work the best for this. I'd now like to read the mission of the Texas State Board of Dental Examiners. The mission of the Texas State Board of Dental Examiners is to protect the public health and safety and promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related informational services to licensees and to their patients. Now I'd like to call on Ms. Nichols to provide roll call to confirm that we have a quorum present.
All right, thank you, Dr. McNeil. Miss Lois Palermo.
Present.
Miss Catherine Sisk.
Present.
Dr. Linda Burke.
Present.
Dr. Robert McNeil.
Present.
And Dr. David Tillman.
Here.
We are all present and accounted for, and we have a quorum.
Fantastic, thank you. Let's move on to item agenda number 3, and I'm going to call on Ms. Nichols to sort of lead a discussion here on the issue of associates in a practice setting. Go ahead, Ms. Nichols.
Thank you, Dr. McNeil. So one of our committee members, Ms. Palermo, requested that we add this discussion item to the disciplinary committee agenda. This issue came out of some of our informal settlement conferences, and we want to ensure that panel members are all on the same page when it comes to discussing a dentist owner's responsibilities when they are in charge of an associate. So Lauren and I had a brief discussion about this topic yesterday, and really legal looks at these cases on a case-by-case basis when we determine whether or not to take action against a owner dentist when they've delegated certain acts. Usually we're looking at how that dentist was involved in the patient's treatment. I added last night, just for your review, 259.004 of the Dental Practice Act, which does lay out the duties of a dentist in certain employment or contractual arrangements. If you'd like to review that, that's basically what we're basing this conversation off of. So I will open up the floor to Ms. Palermo or any other committee members that have thoughts on this topic.
So is this the current statute, how it reads?
Yes, ma'am.
Yes. After reading this and looking at it, I think this pretty much explains everything.
Yeah.
I mean, because it is saying that the owner dentist is responsible for things that are done in their practice. And one of the problems, one of the reasons why I wanted it brought up was because a lot of times it seems like when there's a dentist being investigated, not all of the records of the complainant are given over to the board or to the investigator. And this is pretty clear about the owner dentist is the one that's kind of ultimately responsible for that. So that was one of the reasons. That, and also to the the fact that they are the owner and they are responsible for everything that goes on in their office. But like I said, after reading this, that pretty much says everything. And maybe we just need to make it sure that we all understand these rules. Is there anything in there that you've seen, Ms. Nichols, that we need to expound on in rules or anything?
Well, I think from the legal point of view, if in an ISC, the panel members feel that maybe the agency should have opened a case against a owner dentist, you know, maybe we're pegging this on the dentist who actually performed the care when some ownership should have been taken by the if the panel will let us know ahead of time, we will certainly open an investigation into those situations.
And if I can sort of add to the comments of Ms. Palermo, I certainly share your concern when we're trying to get records from a dentist. They're an associate. We're having a hard time getting records. Now, if we look at that situation specifically, the owner dentist would be the one who controlled the records, and the owner dentist would be the one that had responsibility for that. Is that a correct statement, Ms. Nichols?
Yeah, that would be correct.
Okay, and I certainly see that that's an appropriate time. Now let's take a look at the other extreme. Let's say that Dr. Tillman, in his great wisdom, hired me on as his new associate, and he's allowing me to do class 2 restorations, and I do a poor restoration. You know, is he is the owner dentist? You know, if we're in an ISC, okay, you've got failed SOC for operative dentistry, Dr. McNeil. Are we going to have Dr. Tillman liable for that as the owner dentist? Now, maybe the case I gave was a bad one of him bringing an oral surgeon in to do restorative dentistry. So in that case, you know, that may be a utilization, but otherwise, you know, that may not be the appropriate usage of it. Although in ISC cases, and I've had experiences where there seemed to be a systemic issue going on there, whether it was upcoding, whether usually it was upcoding, or just sort of managing patients in a certain way. We see this a fair amount. You know, we'd see bone grafting of maxillary wisdom tooth sites, 1 in 16, sort of the protocol that was established. And at least in the oral maxillofacial surgery literature, we don't have a whole lot of support for that without some sort of significant other factor that came into play. There, we've sort of gone to the owner dentist and lumped them into the situation. So I think, you know, we have that ability. And I think, Ms. Palermo, to your point, you know, maybe we just have to make sure that all board members are aware of that for ISCs. Anything there, Ms. Nichols, that I said that you would add to or correct?
Everything you said is directly in line with the discussion that Laura and I had yesterday about looking at the situation on a case-by-case basis and where the owner's responsibility really lies and when we should be taking action against them. Like you said, the example you gave is a good example and of when, okay, are we really going to hold this person, the owner dentist, responsible when, you know, the associate has done all the work, did the treatment plan. As long as the owner dentist makes all the records available and is participating, then are we going to take action against them? Probably not. But we've seen situations at ISCs where the owner dentist has their name on all the pre-printed forms and has their name on all of the software and still want to raise up their hands and say, no, I don't take any responsibility because I didn't do the work.
Right. But there are some gray issues where let's say the owner had the diagnosis, the treatment plan, and so there was a part of the provision of patient care. Maybe they didn't do the specific restoration, but it starts to get cloudy. Also, you know, perhaps you go to the associate, the board does, to require records, and there's some, you know, walls that are hit. That does potentially give us another out to go after the owner. Look, we're not getting the records. He's your associate. We need some records within 30 days or whatever. And that does help the board accomplish, you know, its due diligence in a timely manner. So a couple of thoughts. And I know that for me, you know, I look at the procedure, right? If there was a treatment plan that said bone graft on third molar, you know, that's on you, owner doctor, if you made the diagnosis. But if there wasn't one there and then the associate decides to put some bone up in there and charges the patient 200 or 300, whatever, 500 for it, then and more of the onus is on the associate or the person that did the work. So, but that does give a lot of clarification to me. I would like, frankly, to see the TDA, you know, if we could send out improved communication with all the dentists in Texas, because I do think there's some ambiguity or some perception of ambiguity. There could be some improved communication to them. So that would be just one thought. Thank you.
A question for Dr. Tillman on that. If you directed them specifically, what would you want the TDA to sort of communicate to the members?
Just, you know, the owner, we are
For
seeing.
shared responsibility?
Correct. And what the board, you know, is required to do as far as rule or statute, and just to give the owner doctors, say, hey, you know, it's on you. If all of these documents have your name on it, then you have a part in the procedure. You have a part in the care of this patient. So, because I don't think that that's well understood.
And I think to your point, and I think we've probably all seen examples of this, where a new associate dentist comes into practice, they've got established processes in place and consent forms or lack thereof, and they're like, hey, I'm trying to do what I can, and there's a system in place that doesn't have appropriate controls, a system in place that has upcoding of certain things, a system in place that doesn't have written informed consents. And we've sat in those ISCs and said, you know, we probably all thought, man, you poor dentist, this is right at the start of your career and you've had this going on. And is that the sort of thing, Dr. Tillman, that you look at and say, okay, that's a time that we maybe bring in the owner dentist to say, okay, we didn't have an informed consent process established? Like, is that an example?
Oh, definitely. You know, in the end, it's the caregiver's, it's the doctor's responsibility. So it's on the associate. But yes, there is some onus, there is some liability with the owner doctor if he's not providing acceptable, you know, or any consents. Then I think there's some liability there as well.
And that's where I would say, sticking with that example, say that once again, I'm in as your associate and you've got consent forms, and I just decide I'm an oral surgeon and, you know, I'm just not going to get a consent, then that may be a different issue versus you just didn't have a consent process established in your practice that you brought me into. So, Ms. Palermo, does that sort of cover some of the issues that you wanted to talk about and bring up with the committee?
Yeah, it does a little bit, but I would like Casey, underneath 4B, can you tell me exactly what that means? Where it says a person who practices dentistry and has another dentist practicing with or under the person is responsible for all professional acts performed under the name of the person, regardless of whether the dentist has an ownership interest or an employment or contractual relationship.
I think that goes to exactly what we're discussing right now.
Right.
So, and I think that is pretty clear cut. I mean, that you as the dentist owner have to take full responsibility for any acts of people working under your name or under your ownership.
Well, and the other thing that I see in the ISCs a lot with some of the associate practices and other ones that have multiple dentists practicing together is that a complainant will file a complaint, but they've got the wrong dentist that they're naming that did the work. And sometimes it's kind of hard probably to figure out who that dentist actually was. But we have, or I've seen that we've just dismissed a fair amount of cases because they didn't even work there at the time that you know, the complainant was having a problem, and things like that. And would that not come back to the owner dentist providing the name of the one who actually did the dentistry?
Right, and I think I know the situation that came out of that was a situation that came out of ISC recently, and where we had some confusion over who was the treating dentist. The patient didn't seem to know who exactly they saw, and ultimately we did bring the owner dentist and make that person responsible for the acts that happened. That was also the same situation where that owner dentist's name was on all the treatment plans, even though he claimed to have never even touched the patient. He never saw them. So in that situation, it was pretty clear cut that yes, the owner dentist needed to take some responsibility.
Well, I just wondered how difficult it was for our investigators to find out who the actual dentist was, you know, in those cases.
Right. And that was an odd situation too, because there was similar names going on.
Can I ask a question of Dr. Bell if she's on the call? And basically the line of my questioning, falling in with what Ms. Palermo was talking about, it sounds like we have a fair amount of latitude with this issue, and it certainly covers into a gray area. From Dr. Bell's side of the equation, how difficult is it for you to obtain records, or how important would it be for you to have the ability to say, okay, we're trying to get information from the associate, let's bring the owner dentist on into the process before we get to an ISC? Long question.
How difficult is it to sort that out ahead of time, basically, is what you're
Correct.
saying?
As opposed to us sitting in an ISC and say, boy, I wish we had the owner dentist here that could answer these questions.
Sure. I would say we have evolved to try to only open related cases if patient harm is at issue. Based on direction from this committee or the board, or of course, Ms. Nichols, we would be happy to have a matrix, kind of an if-then, you know, if you cannot get the records and this person is not the owner dentist, then we automatically open a related case. I can say that that's not, the issues aren't always apparent on the front end. And there is a delay of a few months. If you open a case, then you have to wait on their response. Then you have to give them time to provide records. And it does drag it out. So at times we will do those things on the front end when it's very clear that that's the only way we're going to get records. At some points, we push the case through with what we have and hope that it's enough to as not delay the resolution of the case. And so, you know, if, like Ms. Nichols said, every case is so different. And so it may be impossible to have more of a matrix or a workflow in terms of a timeline that we would go to these additional links, or at the point at which we would open a case on the owner dentist. That's not always even easy to figure out, believe it or not. And so I would say if we are, whatever we're directed to do, we will do our best to do.
Question
Dr. Tillman?
Through the chair. So if there's a complaint, the dentist is required to have a number of documents within 30 days for the board. There's, I think, from my remembrance, there's a checklist that they go through. Is that accurate? Would there be any possibility of adding a survey question? Did you provide direct patient care in this situation? Some way to get the doctor to respond, yes, they provided the patient care, or if they didn't, who was the attending doctor, so that there could be some improvement. Because we do see, you know, it gets even up to the ISC level. You have the parties there, and then all of a sudden you don't have all the parties there. at that level. I mean, it's on up the ladder, and still there's some disconnect. So I'm just trying to think of ways to make sure that that doesn't happen.
And it would be surprising in that example that they wouldn't have that in the narrative, that it would be, you know, I didn't provide the treatment in question for this patient. I saw them 2 years previously, for instance.
Yes, and that is where we tend to see that information, is in the respondent's narrative. Unfortunately, they don't always choose to provide us with a narrative, and they're not obligated to. And so therein lies the conundrum.
See, they
So
should.
to Dr. Tillman's point, then, if there's an attestation of, yes, I provided care for this patient during the time in question, is that a reasonable thing to add?
That's going to be similar to whether they provide a response or not. That we can't, you know, I think it's a good idea, and it might weed some people out, because of course you think if you got some type of notice that you are under investigation, you want to quickly say, oh, I never even saw this patient. You would, but some might not.
That's a good point. Realistically, the times that I've seen where it's an issue with the owner dentist is usually billing issues and upcoding, upcharging. And that's where the associate dentist will say, I never saw any of this at all. You know, as we've talked about, we have the opportunity during ISC to say, okay, let's open a case on the owner dentist with respect to this issue. And is that our cleanest, easiest approach, as opposed to when Dr. Bell sees a SOC overbilling that she automatically looks for an owner dentist to add to the equation for an ISC?
Yeah.
Ms. Nichols?
Yes, I think so. I mean, unless the DRP member happens to notice, or you know, when they're going through their review and think and points out, hey, we probably should, the owner dentist has some culpability here, then and up until that point, then yes, ISC pointing out would be helpful as well.
Okay. Dr. Bell, from the DRP members, do they get any sort of, have you ever had any sort of discussion or information related to them on this issue at all?
So I've been here 7 years, and when I arrived, this was a hot topic. I believe that the board was going down the path of using this statute and making a rule working with this statute. And we were directed to stop going down that path.
Right.
Right. And so we have ebbed and flowed with the direction as we've seen it. I would say that DRP members often mention they feel there's some culpability for the owner dentist. And again, I feel like my duty is to work within the parameters of our rules and my direction. So they would be very open to any direction, you know, or change in training, or you know, or contemplate those issues a little bit more. What I do encourage them to do at this point in time is to focus as much as they can on the care the respondent provided and was had power over, if you will. But I'm, like I said, at the direction of this committee, the board, Ms. Nichols, I'm happy to follow whatever y'all feel good about.
Any other comments from any of the members? Ms. Sisk, from a
Thank you.
opinion.
Just an observation of mine on being on so many ISCs, which I love doing, by the way, and look forward to more. I have been very frustrated many times, and those of you who have been on the ISCs with me of those frustration times, Dr. McNeil, Mr. Thermo, about the lack of I have a cat coming up here on me. The lack of, gosh, what do I say? How do I say it? responsibility, accepting responsibility for actions when you have a big practice or, and there are many dentists that deal with one patient doing different things over different times. And it's really, they hand off the responsibility. They hand off the, well, I didn't really do, or I didn't know, or this doctor did this and I didn't really do that. That's very frustrating to me when you can't just say, wait a minute, you're responsible for this. You did it. She said you did it, or he said you did it. The patient did. So what's going on here? Why are you guys trying to hand off the culpability, if you want to call it that, to the person down the road? Just kind of kick the can away from you. So that's very frustrating to me. So anything we can do to strengthen our ability to not go after, but to get the responsibility anchored on the person that is responsible, the owner, perhaps, if that's what that means. And anything we can do to strengthen that, then I would really appreciate it from my standpoint in ISCs, take away some of the frustration.
Okay. Dr. Burke, did you have a comment?
Yes, thank you, Dr. McNeil. Unlike Ms. Sisk, I haven't had the opportunity to do as many ISCs, but a comment that I wanted to make, I strongly feel it is the doctor owner's responsibility to make sure that they're hiring competent, capable doctors to work in their clinic. And unfortunately, Ms. Palermo, one comment I wanted to make, it's so difficult for doctors when they hire their dentist because you can't do a working interview. So a lot of times they may have fabulous credentials but have poor hand skills. But I strongly feel that it is the doctor owner's responsibility to early on determine whether or not that clinician is competent and capable and should continue providing care in their practice. I also feel it's the doctor owner's responsibility to make sure to train staff properly on getting consent forms signed, even down to billing, to make sure there's not upcoding on billing. I think that's very important as well. Now, the dentist, let's say, that is being brought up on a charge for an upcoding in a case where they wrote a lab prescription for high noble metal that had it, or charged the patient high noble metal that wrote a lab script for a non-precious metal. I mean, that falls back on the dentist that's being unethical at that time. I don't think that should fall back on a doctor owner. But ultimately, I would like to see us be more strict in holding dentist owners accountable and responsible, because I don't want to see doctor owners feel like they can just hire sub-adequate or subpar doctors in their clinic for production and revenue and not take responsibility. But in the ISCs I've been in, the doctor owners have stepped up and they've tried to care for the patient and they've tried very hard to make it right for the patients that I've had in my ISCs. I think I only had one where the doctor in the ISC couldn't get records. And in that case, I think it goes back to the doctor owner if you're not allowing records to be released.
Anyone else with a comment? Well, I think we've certainly had a pretty lively discussion here. Ms. Palermo, thanks for bringing that up. And that's something that when the full board meeting tomorrow, I'll sort of summarize some of the issues we've been talking about. And maybe to Dr. Tillman's point, points of consideration, perhaps this is something that comes through the newsletter from the executive director that talks about this issue. Perhaps something is sort of fabricated written by the board and it goes out through the TDA newsletter, may be sort of a helpful issue. You know, the bullet part, if owner dentists hear that they're responsible for everything that takes place, I'm sure people are going to sit up and take notice. And it's a blessing and a curse to have such a wide area there. And I think helping our fellow board members to say, hey, this is a tool at our disposal during ISCs when appropriate, but also just notifying dentists of their responsibility. So, okay, any other issues related to this at all? Okay, terrific. Let's move on now. I believe item number 4 for public comments. I did see that we had a written comment that should be in our packet of information that we have. Ms. Nichols, did you have something to say regarding that?
Yes, Dr. McNeil. So Ms. Katla, I'm sorry if I'm pronouncing your name incorrectly. She's actually here, would like to give a verbal public comment whenever you're ready as well.
Does she need to be unmuted?
I just sent her the request. She can unmute herself.
You can unmute.
She's-
Very
okay.
good, doctor. Thank you.
Hello?
Yes,
Hi. Go ahead, Dr. Tillman. You can talk about the time allotment and welcome her.
certainly. If we could, appreciate you coming. If you could limit your comments to 5 minutes and then questions after that, that would be appreciated. Thank you.
So my name is Carla Chase, and I'm coming on behalf of my mother. She was seen at a dentist in Houston, and I don't know if we're supposed to name places and dentists, but the dentist saw her on the same day and pulled 12 teeth, and then pulled 7 teeth 2 weeks later. And my mother was disabled. She had had a stroke 15 years prior to her being seen by the dentist. And she had aphasia, but she could speak in 2 to 4 word utterances. She could also walk with a quad cane. She could feed herself, and she was living at home. Within 2 weeks of the last dental procedure, she winded up having a stroke, and then she also had severe allergic reactions to the 2 medicines that are commonly given for people who would have teeth removed, and for pain, and for also for to prevent a prophylactic, I guess, to prevent the infections. Well, she was allergic to the 2 that was prescribed, and so she had a second massive stroke after 15 years, and then she actually never regained her ability to breathe and walk or eat. She could open her eyes and look left to right. And I did try to talk with the dentist, and later on was pushed to the corporate office, and they changed the paperwork, the initial paperwork that the dentist had provided. And then they also, they added her medical alerts and stated that they reviewed her medical paperwork. And when I went to my mother's primary care doctor to find out when did they request her paperwork, they never requested it. They never called the doctor or anything like that. And they just, when I told the corporate office that changing the documentation was inappropriate and illegal, they just stopped talking to me. And so I'm just hoping now, I mean, my mom is gone. She transitioned, and I'm just hoping that there could be better monitoring and evaluation of what dentists are doing. I did find out that the dentist who performed those procedures on my mother had just gotten licensed a year and a half prior to her doing the procedures. My I don't know how many teeth are normally removed at one time, and I don't know if the local anesthesia is enough for 12 teeth being pulled at one time and 7. And so my aunt is the one who took her, so her sister, my mom's sister, and she spoke for my mother. The dentist didn't ask. My mother actually said no, but there was some documentation on the paperwork saying that my mother was mentally ill, but she was not. But she said no, apparently during the visit, that she didn't want to have her teeth removed the first time, and that was ignored. So anyway, I want hopefully to find out if there would be any way to create more monitoring and evaluation processes for dentists who are treating patients, disabled patients, low income patients, because she was on Medicare and Medicaid, and she had the dental insurance, but was that the proper treatment plan for her? I don't think it was, but I'm not a dentist. I'm a speech pathologist. So, but thank you for allowing me to share.
Thank you. And through the chair, any questions?
Just only if there is a way to communicate to dentists.
Thank you. And any questions from the committee members?
Oh, sorry.
Yes.
Is there a complaint filed?
And-
And I think Mr. has some information for us.
Yeah, and that's what I was gonna address. it's not entirely clear if the case is currently pending or if there is an active investigation. And so
I did.
encourage y'all not to speak about the specifics.
Maybe offline, we could get the information and make sure that we are aware of the process. And that's, I'm sorry your mom had to go through some challenges there. And we have a process in place to sort of look at issues like this, and expert dentists that take a look at the issue and make certain recommendations. So offline, we'll have you sort of connected with people at the board that can see what we can do. Thank you very much for your time, your comments.
Thank you.
Ms. Nichols, any further public comments?
Ms. Palermo, did you have something to add? I thought you were gonna speak. No, we're good. No, I have no announcements unless any committee members have any to make.
Any announcements, committee members?
No.
Okay, well, hearing none, do I hear a motion to adjourn?
I so move.
Ms. Palermo,
I'll
second?
I'll second.
Dr. Burke, thank you very much. All in favor, say aye.
I.
Aye. Meeting adjourned, and the time is 9:42 a.m. Thank you, committee members.
Very good. Thank you.
Doctor.
So we will be leaving this up for the streaming. So if you're on the 10 a.m. committee, I guess that's you, Dr. Burke, and Ms. Palermo.
And me, I think.
Yes, Ms. Sis, yes.
Yeah, I think so.
You can just leave this up if you'd like, and we'll get started at 10.
Okay.
Perfect.
Is it okay to go ahead and put back on mute now?
Sure, we'll unmute you when the time comes. Sure.
Okay, good. I'm going to mute myself. Thank you.
Thank you. Your job is to whisper to Lauren what a good job she's doing.
Oh, well, I'm failing.
Well, you're far away.
far away.
That's why you have
Well,
to be
and
right
also-
here.
Mainstream is unmuted. Let me unmute all the others.
Everybody's here.
Can y'all hear me?
Yes.
Good morning, George.
Good morning, Dr. Tillman.
Looking very official there. Very nice.
Well, thank you. You too. I'm sorry you having to be there.
You know, another night at Hotel Jaja. It was tough. The hardest thing was coming down in the rain, but
Yeah.
it is.
Rain, what's rain?
Yeah,
Right.
We've had a lot of rain here.
indeed. I think we are ready for you.
You want to test out Christine real quick, see if it echoes?
Christine, you want to give us a little test to see how your sound is doing?
Good morning, everyone.
That sounds great.
No headphones.
You want to give us a little test on your sound?
Hold on, Dr. Bell. You want to do it as well?
She was fine.
She was fine. Yeah.
Sounded good?
I think we're good on everybody.
Yep. All yours.
Casey,
Yes.
Are we ready?
so can you hear this time?
Yeah.
Sounds great.
Great, thank you.
Okay. The September 10th, 2020 Licensing Committee meeting of the Texas State Dental Board of Examiners will now come to order. The time is 10:06. Okay, I want to remind board members, if you're listening to the meeting on a secondary device, computer, tablets, please mute until it's your turn to speak. Please say your name before your verbal vote during the voting process to ensure proper count. And I will announce the names of board members when addressing them on their first and second motions. The mission of the Texas State Dental Board of Examiners is to protect the public health and safety and promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related information services to licensees and their patients. And now I'll call on Ms. Nichols to do a roll call for us, please.
Yes, thank you, Dr. Kirsch. Ms. Catherine Sisk,
Present.
Dr. David Tillman,
Here.
Dr. Linda Burke,
Present.
Michael Melcher, Miss Lois Palermo.
Hold on.
I didn't hear either one of them.
I think she muted herself. Hold on. I just asked her about mute. There's Melcher.
There, I
Present.
couldn't unmute myself.
There you go.
I'm present.
Dr.
Okay.
Melcher,
Present.
and then Dr. George Kirsch.
I'm present.
And then again, Miss Palermo, is that
Yes.
perfect?
All right, thank you so much, Dr. Kirsch. You have a quorum and everybody's accounted for.
Perfect. Thank y'all. And thank y'all very much for attending today. Casey, I'll go ahead and turn it over to you for discussion of board exception to the rules for I guess we can lump Dr. Barboza and Dr. Perez together because they're both one and the same thing at the same facility. Can we do that or should we take each one independently?
Let's go ahead. In discussion, we can lump them, but let's discuss each one independently.
Okay.
I'm going to turn the floor over to Lauren. She's going to give us a little brief overview for each of these.
Perfect. Thank you. Thank you, Lauren.
Let Lauren do her thing and then we'll let them in.
Thank you, committee members. Thank you, Casey. So our first case is labeled 2021-Q1-DDS1. And you'll see we provided you the materials in your board meeting materials. And so this applicant is, so board staff is deferring the applicant to the licensing committee for outcome of a full privileged dental license. The applicant holds a current faculty dental license and would like to apply for a full privileged dental license. Board Rule 117.2E requires the applicant to apply by examination. The applicant has not completed a regional or national exam, therefore does not meet the requirements for licensure by examination. The applicant is requesting an exception to Board Rule 101.2A, licensure by examination, and staff is deferring to the board for a determination.
And Dr. Kirsch, they are here, would like to address the board as well, if you're ready.
Perfect. Yes, I am.
Casby?
Yes.
And you can go ahead and let Perez in too.
Do you know if Dr. Kazmetis is here to speak on their behalf as well?
He is,
He is? Okay, great. Thank you.
what you just said.
Oh, okay. They are now in, let me unmute. Barboza has not activated their audio yet.
Dr. Barbosa, if you could activate your audio, that would be appreciated.
Want Perez, then you have muted yet?
You can.
I'm not seeing them.
They're here.
Hold on, I just requested them to unmute themselves.
Hello. Hello, can you hear me now?
Yes.
Yes.
Dr. Barbosa,
Okay, well,
your opportunity to address the committee.
thank you so much. Good morning, all, and thank you for allowing me the opportunity to speak to you this morning. My name is Concepcion Barbosa. I'm a prosthodontist and a periodontist. I also did an implant fellowship at Baylor College of Dentistry as part of the OMS department. I am originally from Costa Rica, but I have been practicing at UT Health Science Center in San Antonio for more than 11 years. 50% of my role there is to train dental students to be competent in fixed and removable prosthodontists in their junior and senior year, meaning in their clinic years. But I also have a faculty practice within the OMS department, where I mainly focus on more complex prosthodontic cases, trauma, cancer, and dental reconstruction of those cases. But I would like to be able to help patients and participate with other colleagues outside the umbrella of the UT Health Science Center. Dr. Kazmetis and the department that he works for is a clear example of this. They do a large number of free fibula flaps. They also treat trauma and cancer patients that at one point will require prosthodontic reconstruction. That together, the clinical, the surgical, and the prosthetic portion of it is a treatment that not a lot of oral surgery departments offer. As an on-staff surgical prosthodontist, I can be involved in the planning and the dental reconstruction of those cases. I do believe that our skill sets together can benefit the population of patients that is currently underserved. And I just hope that you will consider granting us an unrestricted license to allowing us to continue with this mission of treating patients and collaborate with other colleagues outside the university. That's all. Thank you so much for these few minutes that you allow me to just express, my ideas to you.
Thank you, Dr. Barbosa. This is Dr. George Kirch. And I want to appreciate everything you and your husband, Dr. Perez, have done for the community and the good work that y'all are doing. I would not be in favor of giving a full license. I would be in favor of, and we can discuss this in the committee as well, as doing possibly a restricted license. And I'll defer to Casey, our executive director, Ms. Nichols, and Lauren stuttered on this as well. If we could do a restricted license in the hospital setting that they would be practicing in. Therefore, I believe what they want to do is start a residency program, if I'm not correct, with Dr. Kazmetis there at Dell Children's Hospital. And is it possible to do a restricted license? So if in 3 years that they decide, I don't want to do this any longer, they can go set up shop, and which they probably won't do, but they could do it without ever taking a board or graduating from a coded accredited dental school. And that is my concern, is opening that kind of door. And I'll defer to counsel on this to help me through this and help the committee through this, please.
Thank you, Dr. Kirsch. So Could you unmute Christine, please? So I'm gonna ask Ms. Mendez to weigh in here as well, if she has any thoughts on possibly offering a restricted license to these individuals.
You have to unmute yourself first.
So while we're waiting on Ms. Mendez,
Christine, you have to unmute you could. Sorry, go ahead.
so while we're waiting,
I was,
could you just real quickly review, Ms. Nichols, the stipulation that allows dental students or dentists that are unlicensed in Texas to teach as well as practice in the private setting within the school? Can you review that for us? Because it is kind of a unique situation.
It is. Thank you, Dr. Tillman.
So Christine, can I lob that one to you as well? Let me pull it up.
Dr. Tillman, are you referencing the rule, board rule 117.2E?
Yes.
Okay, gotcha.
Okay, so that rule states, license holder whose employment with a dental or dental hygiene school terminates and who is subsequently employed by the same or different dental or dental hygiene school must comply with the requirements for obtaining an original license, except that the person is not required to retake the jurisprudence exam.
Right. Thank you.
Thank you.
Sorry, Ms. Mendez, I interrupted.
no, that's fine. Thank you for that, Lauren. And so as Dr. Kears mentioned, the restricted license, I immediately started looking in the rule, and I don't see anywhere in the rule that we offer a restricted license for someone who has not taken a national or regional exam, let alone completed a CODA accredited school in Texas.
Right.
Okay. Is there any stipulation that they could practice under the license of Dr. Casmides if he allowed that? I know this is a medical school and they're trying to start a residency program. Maybe under his license, they could practice there. If not, I don't see how it's possible for us to grant a license, to be honest with you.
I agree with that. Under the way our rules are written and the way our setup is.
Right. That's right.
I have a quick question. At the very end of the rules and regulations or the Dental Practice Act, doesn't it say that we can grant exceptions?
Sure, and that's why they're here.
Right. So actually a restricted license could be an exception to licensure? Or could it not?
Ms. Mendez, how would that work under this umbrella? Would it be under Dr. Casmides's license and they would have a restricted license to work at Dell Children's Hospital strictly? If they leave that environment, they cannot practice anywhere else?
You're muted.
She can't unmute
Dr.
herself.
Oh,
She was just leaving because I requested it.
You should be able to unmute yourself now, Christine.
Don't mute yourself because.
Does she hear me?
She did. She just can't talk back.
Okay,
There we go.
I'm here. So you asked, the question was if they could work under Dr. Casmides's license.
Under the Dell Children's University, right, exactly, the hospital. And if they leave that setting, they cannot practice anywhere else.
Currently, under the Rule 117.2, which is for dental faculty licensure, that's the only thing that we have for folks to get licensed and who have not taken or graduated from a CODA accredited dental school. So it's
Okay,
not just having graduated.
I'm sorry, as Ms. Palermo stated, so there are exceptions that we can make to the rule. And
There's an exception, yes.
Right. So can we do a restricted license for them in that setting only? If they leave that setting, then they can't practice. I would be willing to compromise and do that. They're doing great work for the underprivileged in the community, and I hate to see that work stop. But I don't want to set a bad precedence by go ahead and opening the door and giving licenses out to dentists who have not gone through the steps as everyone else has.
Dr. Quirch, this is Dr. Perez. Is there an
Yes, sir.
opportunity for me? How are you, sir? Is there an
I'm very
opportunity
well,
for me to
thank you.
speak?
Yes,
Thank you, sir.
Absolutely. Thank you.
Thank you very much. I want to thank the committee for allowing us, to talk about this subject. As you know, we have hold a faculty license for almost 11 years, and
Right.
I'm the program director. I've trained 11 generation of residents, et cetera. Now it's interesting because I signed their certificates, but I can't join their practice, which is fine. We like what we do. We are not the typical, we don't want our typical dental practice, and we enjoy the difficult cases. I particularly enjoy doing orthodontic surgery,
Right.
the total joint prosthesis, et cetera. And I completely understand the position you're in. Because we did not train in the United States and because we did not do our residency here, we are not eligible to take the licensure exam. And to be honest, I haven't done a root canal or prep a crown in almost 20 years. But
Right.
if the committee would grant us an exception to that rule, I would be willing to study and take the licensure exam. And if that's a possibility, if the committee allows us to study and take the licensure exam, that might be a solution. And I just wanted to bring that up.
Okay. Ms. Nichols or Lauren?
Dr. Burke had her hand up earlier. Dr. Burke, did you?
I was just going to also say, we appreciate everything Dr. Barbosa and Dr. Perez are doing. And I know you're excellent clinicians and you provide a great service that a lot of other doctors aren't capable of. I live in an underserved area and I treat a lot of medically compromised patients, and it's very difficult sometimes to find a specialist that's capable and competent. So I see both of you as little gold nuggets that are here to start a residency program to help train other doctors to provide excellent quality care. We're just stuck in a very difficult situation right now because we need to come up with a solution that will help you start this residency program without setting a bad precedence, because we have so many foreign faculty that teach, and we just have to be careful with what we do for certain people and the precedence it might set or a floodgate that it might open. That was my comment. Thank you, Dr. Kirsch.
Thank you, Dr. Burke.
I have a question.
Gentlemen.
Miss
Yes, Ms.
Nichols?
Palermo.
Yes, thank you. Miss Nichols, is it feasible, and I haven't looked at the faculty license as to what they're able to do and everything, but it sounds like at least Ms. Barbosa has been practicing in the UT Health Science Center San Antonio, so it's not like she hasn't been doing procedures already. Is there anything in the faculty license where we could say faculty or restricted license? Or take part of the faculty license and make it a restricted license? Well, not make it, I mean, leave that there, but also for the people, because they have been practicing, it sounds like. It's not like they've just been teaching and not doing the procedures. Am I right? No? I see Dr. Perez shaking his head no. So is that not correct? I can't hear you.
I don't see them. Let's see where they're at.
Can we unmute him, Dr. Perez?
Can you unmute Dr. Perez? Okay, there we go.
Yeah, there we go.
Oh, there's Dr.
Thanks.
Perez.
No, you are completely correct. I have a full faculty practice, and so does Dr. Barbosa. So, I operate 3 times a week, do dental alveolar procedures, dental implants, temporomandibular joint replacements, and they are my private patients. And so does Dr. Barbosa. We've restored countless cases with hybrid restorations, dental implants. She practices full scope of prosthodontics, and we've been doing it for 11 years. The faculty license does not restrict our practice as long as it's within the umbrella of the university. And this has been a year that has opened our eyes because of coronavirus. It's just it has affected everybody, and we really realize how vulnerable we are. We became American citizens, bought our house, have our lives here, if for some reason, whether it's coronavirus or something else, the university no longer needs us, we're essentially forced to leave our country. You know, we are US citizens, but then we wouldn't be able to practice and we wouldn't be able to maintain ourselves. So that's the reason again, I want to really thank you for listening, because it's been one of those things that we don't really have a solution since we are not eligible to follow the regular steps.
Dr. Tillman, I saw your hand up.
Thank you. And the other complicating factor, and it may not be as significant, I know we as a board do not ascribe to or condone programs, but in this program, they are able to practice under a CODA approved program. This program has not been approved yet for instruction under the CODA program. So that also may complicate the issue as well.
Thank you. Thank
If
you,
it's a
Dr.
CODA approved program, that's one thing, but that's not the issue here, because there's
Right.
it hasn't been established yet.
Dr. Kirsch, if I may also bring something to the committee's attention, under our statutes in the DPA, this will be, let me make sure I'm telling you all the correct section before I say this. Section 251.004, which is the exemption from the practice of dentistry. This rule, excuse me, not rule, this statute specifically states that faculty members are not practicing dentistry. So while I can certainly appreciate that they are by trade actually doing dentistry, that's exempted from our rule as the actual practice, which is part of the reason why they have that wide berth to have a full dental license while at a teaching facility. But we can't necessarily, without again giving this exemption, consider that to be the practice of dentistry for X number of years prior to them receiving a Texas dental license. That's excellent. Thank you.
Thank you, Cassie, for bringing that up. Well, committee members.
Dr. Melcher had her hand up earlier. I'm not sure.
Oh, I'm sorry. I can only see 4 people at one time. That's why I'm, let me go to Dr. Melcher. Hey, Dr. Melcher.
Good morning.
Good morning.
I just wanted to know from Dr. Perez and Dr. Barbosa, had y'all ever considered taking the national or the REB while you were a faculty member there with San Antonio? And if so, what prompted y'all not from doing that? Or did you foresee yourself as being in academia all your life?
We can't. We are not eligible to take the licensure exam because we did not train here. So we can't
graduate
register
from a
for
code
it.
accredited school.
Okay.
Right. They had to have graduated from a code accredited school to take that exam.
But
That's
they
one
would
of-
have the opportunity to go and do the program in like 2 years or something.
Right. There's a 2-year program
Right.
that they can do and then go and
Right.
take their exam. That's right. That's right.
Right. So just out of curiosity, y'all never thought about maybe doing that as well?
Well, so if you're talking about the international program that the university offers, we have thought about it. It's a very competitive program. They only take 10 applicants, and I believe there's like 1,000 people that apply for it. You know, we kind of being faculty and seeing our patients, it's our job. So that would mean that we would have to resign our position and become full-time students. I'm going to be honest, we've thought about it. You know, it means kind of going back and doing 2 years of dental school, but we haven't done it. The university has been fantastic to us. The university, and currently they still are, you know, we practice a full scope. I love what I do, and I take care of all these patients that a lot of other people don't, and teach residents at the same time. So we've never really, it's not until now with the opportunity that Dr. Casimides has offered us to kind of expand our scope to maybe Austin and Dell's children, and also with COVID-19 that we've realized, well, you know, we probably should start looking into, you know, how can we either take the exam or have an unrestricted license. But, you know, now it's 11 years after we've been practicing. So that's sort of like where we are.
Thank you.
Dr. Burke, I think she had her hand up, Dr. Kirsch.
Dr. Burke?
I'm wondering if it's possible to hear from Dr. Casimides. Is he here as well, Ms. Nichols, or?
He is, and he should be able to talk. He's not on mute.
Hello? Can
Welcome,
you,
Dr. Kosmides.
hello, can you all hear me?
Yes.
Okay. Hey, thanks for letting me talk. I'll be brief here, but I'm an oral surgeon here in Austin. I graduated from the UT Health Science Center program in '95. I did my dental school, medical school, and oral surgery residency there. And I was in a really successful private practice, and the hospital called me, gosh, I guess 9 years ago to help out with a special needs kid that they had, because nobody would come in and treat this kid that had a bad infection. And I took care of him. Having a special needs daughter, I was happy to do it. And I took care of this kid. And then all of a sudden, they came to me and asked me if I'd start an oral surgery department in the hospital. So I said, look, the one caveat is you let me start an oral surgery residency program down the line. And so here we are 9 years down the line, and they finally agreed to let me do that. Now I have to find the right faculty. I do mostly corrective jaw surgery. I do some wisdom teeth and stuff like that here and there, but I do about 160 cases a year. And so that's my main focus. And most of what I do is on indigent patients, not your kind of private paying type patients. The big missing component for me is TMJ reconstruction, which is what Dr. Perez does. Because we have a huge unmet need of people that need total joint surgery and even simple arthroscopy. And then for Dr. Barbosa, we have a big unmet need for our cancer patients. We do a lot of free fibula flaps and put in dental implants, and the patients leave and they don't have any teeth, and then they can't really get back into the hospital system to be restored because they don't have the funding. So now we're doing this jaw in a day concept where we literally put the implants in the fibula, we resect the fibula and put it in the mouth, and then the prosthodontist comes right in and puts the teeth in, so that this jaw in a day concept happens, and they're restored by the time they leave the hospital. And just trying to recruit the right faculty is difficult to do, and these guys practice at the top of their specialty, and so it'd be incredible to have them join my team in starting this whole residency with Dell Children's and the Dell Medical School. So that's why I need their assistance. And the tough part really is finding somebody that will come work for a reduced stipend, because you're not going to recruit anybody out of private practice just because the pay differential there. And to be able to have them really allow me to complete my program.
Dr. Kosmides, it's Dr. Kirch, George Kirch. Thank you for the work that you're doing and everything that you have done, especially for the indigent patients. The work y'all are doing is fantastic. And this is a very difficult situation for us, to be honest with you. Do you think we may be a little early jumping the gun? Maybe y'all get the CODA accredited that you need for this residency, then come back and maybe we can do a restricted license for them. The way I see it, granting a full license right now, it's probably not a good option, to be honest with you. It's just going to set a very bad precedence. And I would be in favor of revisiting this a year from now, whenever the residency program takes off and y'all do get coded. Dr. Tillman brought up a great point that it's not even a CODA accredited residency yet. And is that correct in me saying that, Dr. Tillman? Is that what you were telling?
Yes, I'm on, but yes.
He said yes. We're having some difficulty right now.
Okay. So I don't know how the committee members feel about that, but
the issue for me is that I've got to kind of put the cart before the horse. I need to get the faculty hired and get this all in place. And it won't be a CODA accredited thing because it'll be through the medical school. Unfortunately, we don't have a dental school here in Austin.
Oh, okay.
So it'll be actually through Dell Medical School and the hospital. And that's the issue. So I'm looking to get the faculty hired now so that we can get this process started. And quite frankly, Dr. Perez would be the head of the program. That's not really my skill set. I would just be one of the worker bees teaching residents because I don't have any experience in running a residency. If that makes sense,
Is it possible to give him some form of medical licensing for him to be able to do this and not a dental licensing? I don't know what the rules or statutes are for medical licensing, and that's something y'all would have to look at. Dr. Burke, I saw you had your hand up.
Well, I just wanted to kind of reiterate, I think just the fear is that if something doesn't turn out with the residency program, or if they decide they don't like it, they may decide to just go out and be in private practice if we
Exactly.
go ahead and grant the unrestricted license. But I think we all agree, and I wish there was a way that we could put them under the umbrella of the hospital. You know, it is a
Yes.
residency program. They're going to be working at the hospital. I mean, they're genuine. We can tell that their heart's in the right place. So I don't know, Ms. Nichols, how, or if there's a way that the board could somehow come up with something that we just say that they're working at that hospital in that setting.
One option might be to have them work under my license there at the hospital, and they work under the hospital, and that's the restriction, saying that, okay, if you leave that hospital, then your only option would be to go back into a faculty practice program.
Yeah.
And certainly I'd be willing to accept that.
Yeah.
And I would not have a problem with that as long as it's allowed by board rule. And that, I leave that up to Ms. Nichols and Ms. Studdard.
I think
That
Dr.
was
Mel-
going to be my question. That was exactly what I was going to ask Ms. Nichols or Lauren Studdard if they could give us information on that.
Right, right.
So we, Lauren and I's recommendation would be that it is not, that this would not be allowed under the DPA. They, like Ms. Kemp pointed out, they have not been technically practicing dentistry with the license that they hold currently. And based on the rules, it just, you know, if they expressed an interest in taking the course, then I think that's the route they should probably take. If you'd like to try to revisit this in a year after they receive the CODA accreditation, that's a possibility too, but our legal recommendation would not be to offer any type of restricted license at this time.
Okay. All right, committee members, do I hear a motion to deny board rule of denial for exception to board rule for Dr. Barbosa and Dr. Perez? Dr. Burke?
No, I want to make one more comment. I'm sorry. Can I just make one last comment? I mean, because I respect what Ms. Nichols just said, and I understand rules are rules, but I mean, I feel that the fact that we have an exception, and I'm so new to the board that I don't understand this, so please forgive me. But I would think when we're thinking about patients and a whole population of patients that are going to suffer because they're not going to receive the care that they need, I mean, I just have a real problem with that. And so I don't know with our exceptions how far we can stretch that. And I know I don't want us to start a bad precedent. But I think we strongly need to think about this because these are patients that no one else typically wants to treat. And so I think really we have to consider that here we have these two doctors that are willing to work for less pay in a hospital environment residency setting and really weigh our different, like what's at stake here. We need to really think about that. But I really take to heart what Ms. Nichols said, and I know rules are rules, and I'm a rule follower. I typically don't like to break rules, but I am struggling with this.
As am I. Yeah.
Well,
I think we all are. I think we all are because we know the great work that they're doing. Yes, Ms. Nichols.
And I'd like to point out that it's not that we're denying them a license. There are hoops they can jump through to obtain a license. It's not that we're saying, go away, we're never going to license you. It just requires some extra work on their end.
Yeah. Totally.
Ms. Nichols, sorry, could you, I can't thank you enough again, all of you, for trying to find a way to help us. But I am not aware, other than training again and doing a residency program, which in my case, I don't even know how I would do that because I'm the program director. So I would be signing my own certificate if I train in the university. But other than that, or going back to dental school, is there another way that we don't know about?
Medical, is that an option?
I don't know. I don't know the medical rules.
Well, I don't have a medical degree.
Oh, I'm sorry.
But
Yeah,
if I did, it is possible. You can take the medical school. It's just that you can sit for the board and take the exam, no matter where you train. That's why, again, I just bring this one more time and then let you go because I know your time is valuable. But is it possible that the exception you grant us is the opportunity to sit for the licensure exam?
Not on this agenda.
Yeah.
Okay, thank you.
I do have one other comment if I can speak.
I'm sorry.
I guess my question is, could they potentially, if the medical school would allow it, could they practice under a faculty license at the medical school so that they could join me?
That's a question for the board.
Right. Yeah, that's a question for the medical board.
Ms.
But I guess
Studdard,
my question is, if they allowed it, would you guys allow that to happen so that he could practice, so that he and his wife could practice with me under a faculty license under the UT Medical School here in Austin?
not necessarily. So Dr. Kirsch, can we let Ms. Studdard speak?
Yes, Lauren, please.
Dr. Kirsch, I mean, it sounds like they're willing to take the exam. The issue is whether y'all would be willing to accept the fact that he graduated from a non-CODA school.
And from my perspective, you know, as a board, if the TDA made a recommendation as a stakeholder, we really can't follow that as a TDA recommendation or even an ADA recommendation. I mean, I think we've gotten into some hot water with that. I don't know if the CODA situation is similar. If we, you know, condoning the CODA, or if we're making a statement as a condoning party to the CODA rules, if that gets us, has a potential question as well. So that would be my only concern. It may not be a concern, but that would be a question. Are we condoning their rules and ascribing to all of their rules if we do this?
That's excellent point, Dr. Tillman. And again, like Casey pointed out, that is not even on our agenda.
Correct.
We're not discussing, right.
So Dr. Kirsch, with that in mind, I would call the question.
All right, board members, there hasn't been a motion made. Can I?
Then I'd make a motion to accept the denial.
Okay, Dr. Tillman, motion to accept denial. Do I have a second? Can I make that motion?
You can second.
I can second. Okay, Dr. Kirch seconds. Any other discussion on the motion to deny request of board exception to the exception to the board rule?
And Dr. Kirsch, is this regarding DDS1 and DDS2 together?
Yes, yes. Dr. Perez and Dr. Barbosa, yes, both of them. Okay. All in favor of the motion?
I would request a roll call, please.
Okay. Ms. Nichols, can you do the roll call?
Absolutely. Ms. Catherine Sisk,
In favor.
Dr. David Tillman,
In favor?
Dr. Linda Burke,
In favor.
Dr. Margaret Melcher,
In favor.
Ms. Lois Palermo,
In favor?
and Dr. George Kirsch.
In favor.
All right, so the motion passes.
Thank you, guys. All right,
Thanks,
Casey.
everybody.
Thank you, guys. Can we go ahead and discuss Dr. Zaid?
Yes, Dr. Kirsch, let me just pull that up quickly here.
Ms. Studdard is going to do a brief intro on this case, and then we'll
Could I-
get him on the line.
Could I have a parliamentary inquiry? Could we have a motion to begin the discussion? Is that appropriate, Dr. Kirsch?
We can go ahead and make the motion and do the discussion.
Please.
Okay, we don't need you. We'll get it. We're getting him on the line now.
Okay.
I would make the motion to accept.
Denial.
Correct.
Okay. Do I have a second?
And this is simply to begin discussions.
That's right.
I'll
Thank-
second.
Dr. Margot Melcher seconds. And now we're discussing.
We're getting him on the line.
Okay, great. Thank you. This is a very similar situation to the first one.
He should be there, Dr. Kirsch.
He's on mute.
He can unmute himself.
Okay, Dr. Zaid, you have the ability to unmute yourself. The committee is ready to discuss your request if you are ready.
Great. Well, thank you guys for allowing me to jump on your Zoom meeting and for actually considering my case. Like very similar to the previous clinicians that were talking on the Zoom meeting before I joined. I graduated from the United Arab Emirates, where I did my undergraduate school from there. And then I moved to Montreal, Canada, where I did my residency in oral maxillofacial surgery. I was awarded the fellowship of the Royal College of Dentists of Canada. And then I moved to the US, where I completed my head and neck fellowship in oncology and microvascular reconstruction. And then I joined LSU here in Louisiana for the past almost 7 years. During that time, I decided to pursue a full dental license. And it has been probably 13 years or 14 years. I didn't do any dental work per se, but I did the licensing exam and I passed both the clinical part as well as the theoretical part. The only thing that's holding me from getting my full dental license is the National Board of Dental Examination. And this is something that I was not requested to take when I was a dental student applying for residency in Canada, because it's not a common thing that the Canadian system uses to get into residency. So hence I didn't do it. And that was my request to the board, if this is something that can be looked at and maybe for your kind consideration, kind of waive that from the request of dental licensing.
Dr. Zaid, it's Dr. Kirch, and again, thank you for being here. Is it possible for you to go ahead and take the National Board Part 1 and 2?
Well, it's like asking anyone who has been out of dentistry for 13 years to go back and study, from me doing free flap reconstructions and head and neck oncology, to go back and, study about prosthetics and prosthodontists. And, it's going to be extremely hard for me to do that at this stage in my career.
And if I read it correctly, you want to move to Dallas and work under the hospital setting as well, with the opportunity to go to private practice. And that's where the concern is. If you were going in just as a faculty member, you could work under a faculty license there. But again, making exceptions to the rules is opening a bad precedent for foreign educated students. And I appreciate everything that you're doing as well. I don't have any. Dr. Burke, do you have anything to add, or Dr. Tillman, Dr. Margot Melcher, Lois? Anyone?
I would probably just agree. Unfortunately, Dr. Zaid, I mean, we appreciate all that you do, but I'm sure after hearing our last session of doctors that we're on, it is, as Dr. Kirsch just stated, a difficult situation we're in, because when we do start granting exceptions, it does open up a floodgate. And so unfortunately, our rules are in place for a reason, and it makes it difficult for us as a committee.
Right. So I'll if you don't mind me saying two things. So one is, it's not like I didn't do the difficult part of sitting after not practicing bread and butter dentistry for 13 years to do the patient-based even exam. It's not like, the dental student these days graduating and doing mannequin exams. I did the patient part examination. As much hard as that was for me to go back and practice how to do a class 2 prep and a class 3 prep coming out from the OR. But we did that. And most of the time, and that's my understanding, is usually you cannot even sit for the licensing exam unless you met the criteria. And I think it's just, I don't know if it was an unfortunate thing or it was unread or anything like that. But, the National Dental Board examination is a great way to set up for dentists. But, at the same time, you have an individual, I'm not trying to brag about myself, but like you have a double board certified surgeon. You have a surgeon who even have a certificate from the American Board of Oral Maxillofacial Surgery and head and neck oncology and microvascular reconstruction. And I don't think at any stage in my career, I'll be practicing general dentistry in the sense that the National Dental Board examination would be contributing to the quality of work you do. So that's why I'm saying could be that the qualification might waive the National Dental Board examination.
Can I
I'd
ask,
leave that to Ms. Nichols or Lauren Stutter to answer that.
I have a question
Sure.
for Dr. Saeed. I saw here that you have a certification of a restricted dental license in Louisiana. And actually that's good through 2021, I believe.
Right.
So what is the restricted license? What does that allow you to do or not do?
Right. So the restricted license allows me to practice full scope under the institution, which is Louisiana State University. Also, it allows me to practice full scope oral maxillofacial surgery in any affiliated site. So for example, in Baton Rouge, I'm the site director of dentistry and oral surgery. This is where I practice 80% of my work. And we do full scope oral maxillofacial surgery, including orthognathic, head and neck oncology, and reconstruction. Also private practice, or we call it faculty practice, which is the private arm of the institution where we do general oral maxillofacial surgery, IV sedation, wisdom teeth. And as a matter of fact, I think that the state of Louisiana is looking into, or the Louisiana State Board is looking into granting me the full license as well. But it had to go through a very similar committee like you guys, and we had to discuss it. And one of the members of the committee asked a fellow periodontist who was sitting on the committee and saying, he asked her if, after 10 years of you practicing as a periodontist, would you feel comfortable sitting for the National Dental Board examination, part 1 and part 2, after practicing for 10 years as a periodontist, where you're very focused in one thing? So the practice is not limited. It's just like, sometimes I'm looking for a different change. And there's also some family reasons that I'm looking into going to Texas.
Dr. Kirsch.
All right, committee members. Thank you, Dr. Zaid. I appreciate it. We do have a motion, and it was seconded by Dr. Melcher. Any further discussion?
I'd call the question. Tillman.
All right, Dr. Tillman has called the question. Can we do a roll call on the vote, please?
On calling the question.
On calling the question.
Okay.
All in favor. Go ahead, Ms. Nichols. I'm sorry.
Ms. Sisk,
In favor.
Dr. Tillman,
Favor.
Dr. Burke,
In favor.
Dr. Melcher,
Favor.
Ms. Palermo,
In favor?
and Dr. Kirsch.
In favor.
The motion passes.
So that's the motion to call the question.
Right, that was a motion to call the question. Now we have to vote on the motion.
Thank you.
Dr. Tillman,
Favor.
Ms. Sisk,
In favor.
Dr. Kirch in favor, Dr. Burke,
In favor.
Dr. Margot Melcher,
In favor.
and Ms. Lois Palermo.
In favor?
It's unanimous. The motion carries.
Thank you, Dr. Zaid.
Thank you, Dr. Zaid.
Thank you. Thank you for having me.
Okay.
All right, committee members, I'll turn it over to Lauren to discuss. Dr. Mandulri, Taru Mandulri.
Thank you, Dr. Kirsch. Dr. Taran Manduluru is applying for foreign graduate dental licensure based on the completion of a specialty in orofacial pain. This specialty currently has not been approved by the ADA. And so therefore, Dr. Manduro does not meet the requirements of having completed training in an ADA approved specialty. And so he's requesting an exception to Board Rule 101.2B. And staff refers to the committee.
Okay. And again, we can start out with a motion of denial. Do I hear a motion of denial on this?
So moved.
Who was that?
Dr.
Burke. Okay, do I have a second?
I second.
Ms. Palermo seconds. Okay, do we have discussion on this, please? Is he available?
He is not.
He is not. Okay. Committee members, how do y'all feel about this? Okay. All right, so we're ready to vote. All right, the motion is for denial for, again, exception to board rule. And we have a first by we have the motion made by Dr. Burke and a second by Ms. Palermo. Ms. Nichols, you would do a roll call for us?
Sure. Ms. Sisk,
In favor?
Dr. Tillman,
Favor?
Dr. Burke,
In favor.
Dr. Melcher,
In favor.
Ms. Palermo,
In favor?
Dr. Kirsch.
In favor.
All right, the motion carries.
Thank you, board members. Okay. Almost done with the dentist. Okay, now Dr. Villarreal, and this was an exception to board rule, and I can start the motion in granting the favor, giving her 6 months to sell the practice. I do understand the situation that this happened. Unfortunately, this dentist passed away. She was in the process of selling the practice. COVID hit, it all stopped, and they're wanting an extra 6 months to leave his name on the practice. And I'm totally in favor of doing that. If I could hear a motion to grant exception to board rule and giving them 6 months.
So moved.
Dr. Melcher.
We all raised our hands.
Okay.
So who is it?
Okay,
Dr.
so
Melcher would like to make the motion.
Okay, Dr. Melcher makes the motion. Who seconds it?
Lois Palermo.
Ms. Palermo, okay. Do we have any discussion on this?
The attorney representing the request is on the line if you'd like to hear from him.
If he wants to speak, I mean, we're in favor of extending the 6 months.
Okay.
So it's totally up to him.
Mr. Lopez, if you'd like to address the committee, now's your time. They're going to vote to approve your request. You are on mute though. Okay, I think we'll just proceed.
It's totally up.
Oh, there you go.
Here we go.
Mr. Lopez, if you'd like to address the committee, now's your
Yes, my name is Nemesio Lopez. I represent Mrs. Elena.
Lopez, please turn off the streaming in the background or mute it.
Correct.
And if you could limit your comments to 5 minutes, that would be appreciated.
Thank you,
Yes,
Dr. Tillman.
I would like to have Mrs. Villarreal address the board.
Good morning, members of the board. My name is Elena Villarreal. Can you hear me?
Yes.
Yes, ma'am.
Okay.
We are voting in favor to support and help you.
Yes, sir. Thank you so much.
Okay.
I don't think I need to add anything to that right now.
Okay, great. Thank you.
Thank you.
Okay, so we have a motion. Any other further discussion? All in favor? And Ms. Nichols, if you can do a roll call for us, please.
Absolutely. Ms. Sisk,
In favor?
Dr. Tillman,
Favor?
Dr. Burke,
In favor.
Dr. Melcher,
Favor.
Ms. Palermo,
In favor?
Dr. Kirsch.
In favor,
All right, the motion passes.
unanimously. Okay, and our last dentist, Dr. Mary James. Again, this is a tricky one, board members. And I'll go ahead and let Lauren give the description on this one.
Okay, so Dr. Mary Catherine James is applying for licensure by exam. However, she doesn't meet the requirements due to not having completed the exam within the last 5 years. She, her exam date is March 21st, 2015. And so she's requesting an exception to Board Rule 101.2C2. She does hold a dental license in South Carolina since June 2015. She does not have any disciplinary action in South Carolina, and board staff defers to the committee.
Committee members, I believe, as I read this in February, she tried to apply, COVID hit. Again, this is a COVID situation where I guess the communication between the board staff and her kind of broke down. She reapplied again in June, which is right at her 5-year mark. She's a couple of months beyond her 5 years. I'd open it up to board members and or committee members would like to hear from them. I wouldn't mind being in favor of granting her this exception, to be honest with you. But again, I'd like to listen to the committee and see what they had to say about it.
Dr. Kearse Tillman?
Yes, sir.
Yeah, I agree with you, Dr. Kearse, but I do have some consternation. You know, we've been a staff that's been present. We've been doing our jobs at home, but there haven't been days, to my knowledge, that staff was not available. So I don't know where the, breakdown in communication happened.
Right.
I'm sympathetic, but when there's a kind of an accusation that the board wasn't responsive or there was a breakdown, I just don't know where that happened. And if it did, we need to find out so that we can correct that measure. But those are my thoughts. Thank you.
Okay.
It's waiting for her to join, so she's possibly having connection issues.
There might be some connectivity issues on her end. She was going to request to address the board or the committee. But if the committee wants to continue discussion while we wait for her, that's probably best.
It was waiting for her to join. Now she just closed out. I guess she's probably trying to get.
Dr. Kearse, Ms. Palermo's in the queue.
Oh, I'm sorry, Ms. Palermo.
Yes, I just wanted to ask, I didn't make a note as I was reading through this. Has she been practicing in, what was it, North or South Carolina since?
South Carolina.
Yeah, South Carolina, since she took that regional exam?
So the exam date is March 2015, and she was licensed in South Carolina in June 2015.
Well, has she been practicing since then there in South Carolina?
That's a question for her.
Clinical program in Houston.
Yeah, Dr. Tillman, I'm reading on her paragraph here, said during this trying and difficult time for all, it has also been hard to correspond with anyone from the board office to expedite the process, which in turn has prevented me from starting my employment. And she also stated that it was hard for her to get, very difficult to obtain the documents needed to finalize my application in a timely manner, I guess from her previous school in North Carolina.
To my knowledge, board staff has been in pretty much constant communication with her, so.
Okay. Thank you, Ms. Nichols, for that clarification. Is she available?
She is not.
She dropped off. So
She dropped off, so.
I think Dan sent her an email. Oh, yeah.
Question?
Yeah.
Ms. Sisk is in the queue.
What happens if we do deny it, and what does she do? Does she start over? I'm not familiar with the process if we deny.
She would have to re-examine and take the whole test over again.
Okay.
Yep.
Dr. Could I add something?
Yes, sir, Dr. Tillman.
In all of these, this is a committee recommendation. Certainly she could join us tomorrow for the full board.
I think I'm in. I don't know if you can hear me now. I think I was having some connectivity issues.
Yep.
Dr. Kearse, she's on.
You able to hear me?
Yes.
Yes.
Yes, Dr. James, go ahead, please.
Great. Thank you so much. I would like to start by thanking you for allowing me to speak with you all today and for your time. I know that you're all very busy. Again, my name is Mary Catherine James, and I'm a newly graduated orthodontist living in Houston. I'm eager to obtain my Texas dental license to begin working in the area as soon as possible. A little background, I graduated from the Medical University of South Carolina with my dental degree in 2015, and I practiced as a general dentist for 3 years in South Carolina. Later, I chose to continue my education at the Louisiana State University Dental School, where I just completed my orthodontics and dentofacial orthopedics program at the end of June of this year. I applied for my Texas state dental license and received the news that I did not qualify by examination. The document went on to further say that due to my regional clinical exam, which you guys have discussed being completed in March of 2015, that I needed to apply by credentials. So I would like to appeal this decision, as I feel that many of the qualifications for licensure by credentials are not applicable to my situation. I would like for you to kindly consider that I can receive my licensure by examination as opposed to credentials due to the following. As stated before, I completed my clinical board exam in March of 2015, and I completed dental school in May of 2015. I exceeded the 5-year threshold by a matter of months. As for licensure by credentials, it requires applicants to pay a fee of $2,891 to receive their Texas dental license. And I really hope that you could consider my current financial situation. While having been in residency for the past 2 years, I had zero income, and what little savings I had after paying down my student loan debt was utilized for cost of living while in residency, as well as to move from Louisiana to Texas. Also, due to COVID, many things that were certain in the new year regarding my future were then very suddenly uncertain. I had a job opportunity that presented itself prior to COVID, but as you all know, things became very uncertain and difficult for everyone. Thus, not applying sooner and prior to my 5-year mark was not an oversight on my behalf, but a result of the rapidly changing job market due to the pandemic. I also saw that for application by credentials, I need to show a proof of CE credit over the last 12 months. Again, I've been in orthodontic residency for the past 2 years, completing many hours of didactic and clinical education with orthodontic CE. I thankfully do have a job offer lined up in Houston, but obviously is contingent upon me obtaining my dental license here. I would like to start working as soon as possible and have been eager to do so these past few months. And I sincerely hope that you will understand my personal situation and hopefully empathize with the recent graduate. All things considered, if you all as a board do not feel that I qualify to obtain my license by examination, I would love if you could please provide me with instructions regarding how to go about obtaining my license by credentials, although I may not satisfy some of those current requirements. So again, I truly appreciate you having me here today so I could explain my situation at hand, and I will hope you will take into consideration my appeal. Thank you very much for your time.
Thank you.
Ms. Palermo has a question.
Yes,
Yes.
I was wondering, so for the first 3 years you practiced in South Carolina and then went to Louisiana for residency.
Yes,
Was
ma'am.
that in orthodontics, and is that what you plan on practicing if you get your license here?
Yes, ma'am. So I practiced as a general dentist for 3 years and then did the 2-year residency in orthodontics. So I would be practicing orthodontics in Texas. Yes, ma'am.
Point of clarification, Dr. Kirsch, through the
Yes,
chair.
sir.
Did you, during your residency, not receive any stipend or salary?
We paid for residency.
Interesting.
Hmm.
Thank you.
So board members, we can either make a motion to make a denial or in favor of board exception rule. And I'll leave that to the committee to throw out a motion and we can discuss it and vote on it.
Dr. Kirsch?
Yes, sir.
Seeing no movement, so I'd make a motion for exception.
Okay. I will second that, Dr. Tillman.
All right, Ms. Sisk,
In favor.
Dr. Tillman,
Favor?
Dr. Burke,
Favor.
Dr. Melcher,
In favor.
Ms. Palermo,
In favor?
Dr. Kirsch.
In favor.
Okay, the motion passes.
Thank you all very much.
You're
Thank you.
welcome, Dr. James.
I
Thank you.
appreciate it. Thank you.
Okay, board members, our last dentist, Dr. Leon James.
And he is available, right?
Yeah, he's in.
Okay.
He can unmute himself.
Lauren, you want to go over his background and what's happened and let the committee, okay, please, thank you.
So Dr. James voluntarily surrendered his license in 2017, and so he's here to you before you today to reinstate his license. The basis of the voluntary surrender order, there were failure to meet minimum standard of care violations, failing to meet the duty of fair dealing, failing to maintain and keep adequate records, failing to advise his patients of the closing of his office, and failed to comply with the board investigation. He also failed to comply with the terms of a 2014 board order that he had, and staff to the committee.
Okay. I will go ahead and, Dr. Tillman, can we open it up with a motion and then hear from Dr. James?
I've requested him to unmute. He's on his phone, so.
Okay. They're gonna make a motion anyway. Sure, go ahead. Sure.
I will go ahead and make a motion of denial. Can I make that motion as being committee chair? Can I make that motion or do I need that from the committee?
Another committee member should make that, I think.
Okay, okay.
Dr. Melcher will make the motion.
All right, Dr. Melcher.
From the words of Alex Phipps, it's poor form, so, sorry.
And Lois Palermo seconds it.
Okay, so we have a motion of denial from Dr. Melcher, a second from Mrs. Lois Palermo. And now we'll get into the discussion.
And he is online. If he would like to unmute himself, he can address the committee if you're ready.
Earlier, he had his name and then his phone. Now it's just his phone, so.
Leon, Dr. Leon James.
Hello?
Yes, we can
Hello?
hear you.
Dr. Leon James. Yes, sir. Go ahead.
Yes, how you
please.
doing?
Good, good. You there? You there?
Well, he muted himself again.
He muted himself again.
So while we're waiting, if hopefully he can hear us, if he could limit his comments again to 5 minutes, that would be appreciated.
Thank you, Dr. Tillman.
Unmute him. Great.
I always forget to say that.
It's all right.
Dr. Leon, now is your time to address the committee. If you'd please unmute yourself, and if you're streaming the meeting in the background, please silence it.
Okay, can you hear me now?
Yes.
Oh, yeah, perfect. Yes.
Okay, sorry about that. Good morning to the License Committee. I would just like to take the opportunity to apologize to the dental board and any former patients that, affected from my actions. Since I surrendered my license, I had time to reflect my deficiencies as relates to practice management care, treating medically compromised patients, and record keeping. I've made every effort in correcting my faults and becoming a better dentist. This journey really has taught me the valuable lessons of self-reflection, humility, and redemption. I am respectfully requesting for my dental license to be reinstated. And thank you for your consideration.
Dr. James, just a point of clarification. Why did you surrender your license? Was it to avoid all the penalties the board was giving you?
No, sir. Actually, I wanted to go in front of you guys to explain what happened. But my attorney advised me to just do a voluntary surrender.
Right. And what was the purpose of that? Why did he advise you to do that?
I have no idea. We was actually supposed to meet with the committee that day, and he just advised me at that point to surrender the license and then reapply the following year.
And
I
you know how
did not
hard you
agree with
work.
him.
You know how hard you work to obtain that license in Texas. Is that correct?
Yes, sir.
Why
I
would you
understand
voluntarily
that.
surrender it?
Well, I guess he felt that was the best route based on what was happening. And I did not agree, but he's the attorney, and he was talking to, I guess, the attorney that was in charge of my case at the point, and I guess he felt that was the best route.
Okay. Committee members, any other questions? We have a motion of denial on the queue and a second by Lois Palermo. Any other further discussion? Ms. Nichols, you do a roll call, please.
Yes, sir. Ms. Sisk,
In favor.
Dr. Tillman, Dr. Burke,
In favor.
Dr. Melcher,
In favor.
Ms. Palermo,
In favor?
and Dr. Kirsch.
In favor. So the motion carries unanimously. Thank you, Dr. James.
So it's been denied?
Yes, sir, it has.
The committee recommendation that will go to the board is to deny.
So you'll have an opportunity tomorrow in front of the board, if you'd like, to state your case.
Okay. All right. Thank you for your consideration.
Thank you, sir.
All right. Bye-bye.
Bye-bye.
Okay.
Okay, now, Ms. Nichols, if you can talk about the dental assistant program, trying to get board accreditation.
Yes, thank you, Dr. Kirsch. I'm going to turn the floor over to Ms. Studdard.
Okay.
Committee members, the Center for Healthcare Professionals Houston Community College submitted an application for the committee's review to become an approved registered dental assistant course provider pursuant to Board Rule 114.21. And the materials are in your, the application is in your materials for your review.
I looked at the material and I don't have a problem granting this. I don't know how the other committee members feel.
I think it looked good.
Okay. Thank you, Dr. Burke. Dr. Tillman, you get a chance to look at it?
Yes, sir. I'm in agreement.
Okay. We'll hear a motion to go ahead and for approval of this, Dr. Burke. Okay. Do I have a second? Can't see everybody.
Dr. Kirsch?
Yes, ma'am.
So I did have a question on their part 5 on agreements.
Can we go ahead and get a second on the motion and then?
Second that, Dr. Kirsch.
Okay, thank you. Okay,
Right,
now let's, okay, so we have a second by Dr. Tillman. Okay, now discussion. Go ahead, Dr. Melcher.
Okay, on part 5 agreements, it has C, to provide appropriate supervision by a licensed dentist if the course has a clinical component involving live patients. Do most dental assisting programs, they don't have live patients, correct? Isn't it more just like simulation, or they go to do like a rotation or an internship at a dental office? They're not bringing them into the school. It's not like a dental or dental hygiene program. So I have an issue with that statement on there.
Dr. Kirsch?
Yeah.
So is there rotation in a dental office with live patients? Is that a part of that educational process? Therefore, you can make the statement on live patients. Is that accurate?
I think that's what it's saying. I believe that's what it's saying. I don't think they're bringing patients in. I think Yeah.
Well, I would just suggest then to change the verbiage to state at a rotation, observing or shadowing a dentist, with live patients or whatever. But I just, the way that I'm perceiving the verbiage on that is that they are bringing in patients to assist with this dentist. It doesn't at their site. So I would just rather change the verbiage, have them change it.
Okay. All right, we still have a motion to accept this, and we have a second. So is there any other discussion? All right, Ms. Nichols, can you go ahead and do a roll call on this?
Sure. Ms. Sisk?
In favor.
Dr. Tillman?
Favor?
Dr. Burke?
Favor.
Dr. Melcher?
Not in favor with that. How can I say it without the verbiage, changing the verbiage?
It's just
Opposed.
It's just opposed.
Okay, so then oppose.
Okay.
Ms. Palermo?
Well, couldn't she have done an amendment?
Yeah, I can do that. I'm willing.
We're in the middle of a vote.
Okay.
Yeah.
Well, then I vote no as well.
Okay. Dr. Kirsch?
In favor.
All right, so the motion carries.
Okay. And again, it has to go through the board tomorrow as well.
Right.
Yeah. Yeah.
I'm just bringing that up just because I know the term live patient has a big thing right now.
As we're about to discuss.
Right.
Yeah.
Hey,
Okay.
Ready, I'll move on to item number 6.
What's that?
Oh, I'm sorry.
Yeah.
So a representative from the program would like to address the committee.
Oh.
I'm sorry, I didn't catch that. I didn't know if she's on the line. Is she still on?
I'm letting her join right now.
It's Ms.
She's
Garza.
online now and she can unmute herself.
Ms. Garza? You can unmute yourself if you'd like to address the committee. They have made a recommendation to the board to accept the program. So if you'd like to address the committee, now's your time, but you are on mute. If you'd like to unmute yourself and address the committee, please limit your comments to about 3 minutes.
All right, thank you. I appreciate that. My name is Rosalinda Garza from Houston Community College, and that's what we were looking for, to be able to provide this course to our Houston Community College students, and also to be able to offer that to those in the community.
Thank you, Ms. Garza.
Thank you.
Thank you.
The committee has made the recommendation and it will go to the full board tomorrow. Thank you. Okay, so Dr. Kirsch, if you're ready, I can move on to discuss item number 6.
Yes, ma'am, please.
Okay, great. So this is the proposal to amend 101.2, which is licensure by examination. This amendment was discussed at our June 5th, 2020 board meeting, and the committee made a recommendation to the board to proceed with a rule amendment. The board agreed and voted that a rule amendment should be proposed. This amendment, which you all have before you to view in your materials, will update the language to clarify that clinical examinations must use live patients except in certain unforeseeable circumstances which would prohibit a live patient examination. This amendment also recognizes the Northeast Regional Board became the Commission on Dental Competency Assessment. This rule will is up for proposal based on whatever the committee's recommendation is here today. Should the board also approve it, it will need to go to the governor's office for review, and if approved, would be published in the Texas Register as a proposal. So I open up the floor to the committee.
I'll go ahead and start. I have contacted a lot of people, including the deans of dental schools, to really, we're trying to do what is best for our patients here in Texas and protect the public. And I know we have come a long ways with how we examine our students. And I know the simulations and the simulators and the typodonts are very good. They don't simulate a live patient. They don't have a tongue. They don't have the head movement. They don't have vocabulary. But I see the other side as well. This is a very difficult topic. It really is. And the way the board rule is written right now, we are giving full autonomy to the REB and all the other examining board rules on how they regulate our exam. If they wanted to choose not to use live patients or a simulator, they could do so. And we wouldn't have a choice because we've written that in our rule. I am willing to compromise on live patient and put slash simulator in places where it's needed. There are situations that I spoke to several. It was one particular board member who expressed to me when they went through the board process and were taking the exam, a rubber dam was taken. The patient took the rubber dam off, walked out, and this particular individual failed the board. And I've heard from other students where patients are extorting money from dental students. They know how important it is. So I see both sides. I really do. And I'm trying to make the best decision for the citizens of Texas. How can we really examine these kids coming out? I know that the American Dental Association of Hygienists and the Texas Dental Board of Hygienists are completely against live patients. And it surprises me that they are in complete in favor of not the live patients, because Miss Marianne Tackman, during our last emergency board meeting when we were, and I don't know if I said her name correctly or not, she made a comment that really bothered me. And this is in her letter written in August 21st, 2020. And it was to Casey Nichols. And it was the Texas Dental Hygiene Association. And it says many patients may be receiving substandard treatment due to not allowing them the use of these techniques. And she was talking ultrasonic scalers. So if she is concerned that hygienists are doing substandard care, and we are teaching this in our dental schools, and I read again in her later letter addressed to me this morning, I got a letter from her saying that some calculus is tenacious, some calculus is not tenacious. Well, that is life. That's patients show up in your chair, and we don't have a simulator. We have a live patient that has tenacious, and you've got to learn to clean that. So, and I get it. We want a fair examination. So I'm really torn on both sides. But I do like the word live patient in that, since we can control a little bit of how our exam is done here in Texas. And I'll leave it at that. I'll open it to Dr. Tillman or Dr. Burke, Dr. Melcher, whoever wants to speak on this behalf.
Thank you, Dr. Kearse. I'll throw my comments in. I totally agree. I think there's an aspect of the examination that is lost when the typodont is used, when the live patient's not used, that we simply cannot reestablish until we have that live patient. I would agree. I mean, I would disagree with Dr. McNeil, and I'm sure we'll hear his comments tomorrow. But I think there is a specific aspect of the patient experience that is not experienced if it's on a mannequin or an unlive patient. Thank you.
Thank you.
Ms. Palermo.
Yes, I had a quick question. Do the students not work on live patients for 4 years in dentistry and 2 years in dental hygiene?
Right.
They're not working on typodonts or anything. They're working on live patients. So
Exactly. So why not examine them with live patients?
right.
Why examine them with?
That's exactly my point.
Yeah, yeah.
It's like, I think it would, until they can actually have a simulated exam that is proof to me that is equivalent to a live patient, I still want that live patient.
Yeah, I totally agree, Ms. Palermo. And you're in the trenches. You're the one, you're in there cleaning, you're doing this. So yeah,
Right.
thank you. Yeah.
Well, and I've done a lot of dental hygiene exams as an examiner. And I can tell you there are some that have obviously passed through a dental hygiene program. I hate to say it, but have definitely, to me, I don't count. I don't make a note of how much everything is worth when I'm an examiner or anything. I just do the examination and put down what I see. It's totally anonymous. I don't know if the schools could ever do that, where we have such great regional exams that provide that anonymity. And I just feel like we should continue with the live patient exams.
Dr. Hirsch.
Yes, Dr. Melcher.
Dr. Burke.
Oh, Dr. Burke, I'm sorry.
No, that's fine. That's fine. I
I
also
can't
just
see
wanted-
everybody.
It's
There we
okay.
go.
I
I
just
see
wanted
you
to
now.
say I also am in favor of live patient. I know I was the first, because I'm an older dentist, in the first graduating class that sat for the rep. And so prior to that, I proctored for the Texas State Board of Dental Examiners when it was just regular beforehand. But on patient selection, if you had a patient and the tooth got pulped, then you basically failed because even though the caries led you to the nerve of the tooth, the state board examiners failed you because it was poor patient selection. And so I think a lot of that comes into play, and I agree, there are just things you can't simulate on a bench exam that make you a great dental hygienist or a great dentist. And so I really am in favor also of live patient.
Thank you.
So Dr. Melcher here. I am having a difficult time with this decision just because I am in academia, and I do see how hard the dental and dental hygiene students do work in their competencies, their requirements and clinic, didactically, simulation, all of that stuff that they're taught that's part of their curriculum. My concern comes when individuals feel like the testing, and I think it was written, flawed and unethical. So I wondered what that stemmed from, because I don't want students to feel, a future dentist and hygienist, that they're testing last part to become a professional in our great field of dentistry, that they felt that was flawed or unethical. So I'd really like to find out a little bit more about that. My second comment is, out of the nation, how many other states have gone to a non-live patient? Are we like, say, and I'm just going to use this out there, are we like sort of the local anesthesia is for hygienists, 1 in 4 states left, in the US that don't do it? So is that something that maybe we need to listen to a little bit more? So I'm just throwing all of these things out there that I've sort of struggled with, and with the voting on this, I too feel like, the REB or whatever examination, if the student has done what they are doing and is competent at that point, then it shouldn't be a problem to pass the test. I was one of the Texas State Board test takers back then. And, for hygienists, we did not have anesthesia. We did not have cavitrons. We did all these other things. So it was a little bit more, there was a lot more involved to testing than there is now. So I sort of feel like for dentists and dental hygiene students, if they're prepared, ready, clinically, then taking a clinical examination on a live patient should not be bad. But I understand there are predicaments. We encountered one this year with COVID, and I think we did the right thing by what we offered. And so I just sort of struggle because of being in academia and being a clinician too, and knowing how, as the board, how we said that we are here to protect the people. So those are questions I'm just throwing out there to y'all, or things to think about. Thank you.
Ms. Sisk, we haven't heard from you. Do you have do you want to weigh in on this, or would you rather sit out?
Just my personal experience. I don't want anybody working on me that has not been tested on a live person.
Okay.
It's just like, it's like any simulator, they're at fault. So I would like to have my people work on me after they've had their testing on a live person.
That's great insight. Thank you. So Casey, is this a motion that we have to, do we have to vote on this, or?
It'll be your committee recommendation to the board, whatever you'd like to recommend.
Okay. And you did make a stipulation as to a national disaster or exception. Is that correct? That's the verbiage is in there as well.
That's correct. So at the board meeting in June, I believe Dr. Melcher was the one who initially brought up this point about if there was some sort of pandemic or natural disaster. So we went with a more broader definition, and just said unforeseeable circumstances.
At the board's discretion, is that correct?
Discretion, correct.
Okay, yeah, I like that a lot. So do I need a motion for this or no?
Yes.
Okay.
So whatever your recommendation is.
Motion to adopt, Tillman.
Okay. Do I hear a second? Dr. Burke?
Motion to propose, I'm sorry.
Go ahead, Dr. Tillman.
I'm sorry, motion to propose, thank you.
Oh, yeah.
And Dr. Burke, you second that?
Yes, I second.
Okay. All right, any further discussion? Can I lump the hygiene and can we lump both of these together?
Let's do two separate, please.
Okay. Yeah. So which one is this? Is this the dental?
For dental, which is 101.2.
Okay, all right. Any further discussion on the motion? All right, Ms. Nichols, if you can do a roll call.
Sure. Ms. Sisk?
In favor.
Dr. Tillman?
Favor.
Dr. Burke?
Favor.
Dr. Melcher?
In favor.
Okay. Ms. Palermo?
In favor.
And Dr. Kirsch?
In favor.
All right, the motion passes unanimously. All right,
Okay.
I'll briefly, if you're ready for me, Dr. Kirsch, go over 103.2. It's the exact same rule, but it applies to our dental hygienists. We did receive 2 public comments from the Dental Hygiene Educators of Texas and the American Dental Hygienists Association in opposition of this amendment. But the verbiage is essentially exactly the same as 101.2. It would require live patients, except in certain unforeseeable circumstances as determined by the board. It also amends the Northeast Regional Board and recognizes that it's now the Commission on Dental Competency. Thank you.
Okay. Do I have a motion to accept?
Propose.
To propose.
Motion to propose.
Oh, Dr. Tillman motion. And is there a second?
Second.
Dr. Burke, okay. Any further discussion? Okay, Ms. Nichols, can you do a roll call for us, please?
Sorry. Ms. Sisk?
In favor.
Dr. Tillman?
Favor.
Dr. Burke?
In favor.
Dr. Melcher?
Favor.
Ms. Palermo?
In favor.
Dr. Kirsch?
In favor as well.
All right, motion passes unanimously.
Okay. Ms. Nichols, do we have any public comments?
We do. Let me find out how many. So far, just one.
Okay.
And it is Miss Jeannie Binder. And I believe she represents one of the
It doesn't show that she has audio enabled, so she needs to enable that first.
Okay, so if she represents one of the associations, and I can't.
American Student Dental Association.
American Student Dental Association, thank you. And Ms. Binder, if you are on. Hi, Ms. Binder.
Hi, are you able to hear me?
Yes, so the case is ready to hear your public comment. If you could please limit it to 5 minutes.
Absolutely. Thank you so much for your time this morning. My name is Jeannie Binder. I'm a fourth-year dental student at UT Houston. Looking forward very much to graduating this May and starting to practice general dentistry here in Texas. I am also the immediate past editor-in-chief of the American Student Dental Association, and also a student commissioner on the Joint Commission of National Dental Examinations. And so I'm here today to speak on behalf of ASDA and the over 22,000 dental students that we represent across the country. I want to point out that ASDA believes that an ideal licensure exam does not use human subjects in a live clinical testing scenario, is psychometrically valid and reliable in its assessment, reflects the scope of current dental practice, and is universally accepted. And in that light, we would like to urge the committee to not adopt the term live patient into the official rules for initial licensure. This practice of using human subjects to test clinical competency has been proven to be flawed and unethical, as Dr. Melcher mentioned recently. So the results of the clinical dental licensing examination have not shown a positive correlation between success in dental school and the student's performance on the exam. Studies confirm that the use of human subjects makes the exam impossible to standardize and misclassifies at least 20% of candidates who must retake the tests, plus an unknown number of candidates who pass the tests by luck and should not have been granted a license in the first place. Pursuant, Dr. Melcher, to your comments about why the exam is considered unethical, students may feel forced to treat lesions prematurely, purposefully create a lesion for the examination, take unnecessary radiographs, and neglect follow-up care. And year after year, we hear stories of these situations that arise for our graduating dental students who are seeking licensure. As future clinicians, we do share your goal of protecting the public, and we do not want to put our patients in a situation where they are receiving unnecessary care or unable to receive the comprehensive care that they do require. ASDA is not alone in pursuing eliminating the use of human subjects in live clinical testing scenarios. In an ADIA survey of dental school deans in 2003, 82% felt that the clinical licensure examinations were not valid for decision-making purposes. And more than 90% believe that change was necessary. Since then, ASDA has helped create the Coalition for Modernizing Dental Licensure, which includes ASDA, the ADA, ADIA, and several state board associations. Right now, we're at more than 60 organizations who are supporting the efforts to eliminate live patients from licensure exams. We know that the regional testing agencies have realized the issues with our live patient exams and have developed alternatives that could be used by state boards. We also have the DL-OSCE, which has been developed by the JCNDE and the ADA that has been vetted for reliability and validity. We do really appreciate that during these extraordinary times, you have considered these alternatives for licensure. And we hope that as we move towards the future, we continue to look at ways that we can move our profession forward rather than staying in the past. And so we would just like to conclude by strongly urging you to refrain from using the term live patient for clinical examinations. Thank you so much for your time. We really do appreciate your consideration.
Thank you.
Thank you.
Dr. Kirsch, I have a couple of questions for Jeannie. Jeannie, you mentioned when I questioned about what was it of being flawed and unethical, you stated there were lesions that y'all felt that were being treated, premature lesions, I think that's what you stated, and then there's unnecessary care, is that correct?
Yes, in the sense that there's a lesion that we may not drill on in clinic in normal scenarios, but are used for REB lesions. I'm thinking specifically class 2 lesions that we would maybe try remineralization strategies on first. But because they're what's available in the student's patient family, the patient can come in for REB, then they are, they go ahead and drill and fill those when we wouldn't do those typically in practice.
Okay. And then as far as, I know ASDA is composed of all the dental schools in the US. Out of all of the schools or in the states, do you know approximately how many of those states are doing non-live patient testing?
Yes, I have that information here. So we currently have 6 states who are accepting the DL OSCE, which is the ADA exam. That's Washington, Iowa, Colorado, Indiana, Alaska, and Oregon. 23 states now accept mannequin exams as a path to licensure, and then 19 states accept mannequin as a temporary or provisional path to licensure.
So the
And we'd be
majority
happy to
states
share
is-
any of those materials with you if you
No,
would like that.
this is helpful. Thank
Okay,
you for
great.
that information. I have no further questions.
All right. Any other public comments?
Nope. We have none.
Okay. And I don't have any further announcements. So committee members, great job today. Thank y'all very much. Do I hear a motion to adjourn? Ms. Nichols, do
make
you
a
have
motion.
anything? Does anyone have any further announcements? Okay. All right. Do I hear a motion to adjourn?
I'll make the motion to adjourn.
Dr. Melcher, do I have a second?
I'll second that.
Ms. Palermo, all right. And just by voice, aye.
Aye.
Aye. Great. We are adjourned and the time is 11:46.
Thank you.
Bye.
Thank you, guys.
Bye-bye.
See y'all at 3:30. Bye, Linda.
What's at 3:30?
It's that, yeah.
I've got to see. I got to see.
The next committee is dental practice at 12:30.
Is there something at 3:30 we're supposed to be at?
CE review, anesthesia is at 2, dental practice at 12:30, CE review is at 3:30.
Yes, so we
Gotcha.
don't need to
Okay.
come back, Margot.
Thank you.
Go out and enjoy the weather.
Yeah.
Bye.
Bye.
So
Hello. Where's Henderson is turned invisible.
He's never looked better.
Ooh, I hope you didn't hear that. Oh boy, we're gonna get off to a bad start with that comment. All right. I don't see a Henderson there.
I think he turned his screen off. So I saw your email about Miss Jones. I think
Right.
Miss Jones might not be able to attend today because she's having some illness issues, or she had a doctor's appointment. And we have not heard from Mr. Bustamante, but with Dr. Tillman present, we'll be able to move forward.
If we can find Henderson.
Present.
Yeah.
Oh, Henderson just texted me and said he can't turn the camera around.
Oh my God. Can you sit in that chair?
Yeah, why don't you sit in that chair?
No.
One on the front, one on the back.
He is technologically challenged. We all know that. Are we live?
Not yet.
Yes.
Oh,
We are.
Yes,
we are. Everybody smile.
Okay.
Yeah, once you
Smile for the camera.
unmute it, it's,
Oh, okay.
I mean, it's still been live this whole time, just with that, we're on lunch break.
Gotcha.
Ooh.
Oh, okay, so, hey, David,
Yes, Tillman or you?
you,
Yeah.
you.
Yes, sir.
Or maybe Tillman, is Chris in the room where he can tell me how to turn this
There he
surface
is.
camera around?
Yes.
He is.
Okay, so if you hover over the up arrow next to the video part, you'll actually see Microsoft Camera Front, Microsoft Camera Rear.
You see where it says stop video on the bottom?
Yeah.
Click on that little up arrow and you'll see which camera do you want to select.
Whatever it's on, do the other one.
Do the other one, huh?
Yeah.
There.
Hey.
There we go.
Is that good enough? Well, I don't see anybody else. So how do I see everybody else?
We want you to do the first one. We like the chair better.
So his view.
Oh, he probably sees a black screen. So in the top right
Yeah.
corner, click on
Top right corner there,
you want
Okay.
it view, not speaker view.
gallery view. You see that
Well.
button up there? Hover over it and it'll go gallery view. Speaker view or gallery?
Gallery.
Go gallery. Or just look at a black screen.
Yeah, well, I think I'll just look at myself. I can't figure that out.
Do you not see the
And the
what we're talking
Zoom
about?
meeting, the square with Zoom meeting in the upper right corner. It says full screen, show no video participants. Then there's speaker view or gallery view. Do it on the other one.
I don't see any of that.
What do you see in the top right corner?
A little square, and when I cluck, it's like a arrows all pointed in.
Okay, so that's full screen. You don't see anything next to it as far as
Go in the black screen, not the white, but the black. In the corner of the black.
Corner of the black. There's a arrows in upper right hand corner. Just me. I can make myself bigger and smaller.
I'm open. Anything I could say would be wrong.
yeah.
Yeah.
Okay, let's try this real quick. So at the bottom, do you see share screen?
Do I see share screen? Yes.
Wait a minute, no, I have that disabled. Actually, that's sure.
Host has disabled my share screening.
Yeah, hold on one second.
Just a second.
They're going to help you out.
Don't push anything or it'll blow up.
Okay.
Can we
I'll
trust
touch
you
it.
to use monitors to sedate patients?
Yes, yes.
Yes, doesn't involve a computer.
State of Texas.
It's We go back to chime, it'll work fine.
Okay, let's do that real quick.
I can see David you now.
That's all that matters.
That's all you need to see.
Okay.
So
Perfect.
then there's it goes from one square to like 6 squares up in the upper right corner.
Nope.
Okay, yeah, I guess you'll look at David U.
Well, now I just have the TSBD live stream showing. You went away.
Somebody has it on speaker, which is fine. You can see us, right? Because you have the stream going.
No, but I can pull it up on my other computer.
You could pull that up and then mute it if you want, and then that way you can see us.
Now I see everybody.
You see the image. Now that's what we're talking
We
about.
do too.
Do you see that in the top right hand corner?
Yeah. Now I see a view.
Well, that's
on
my
YouTube.
Do you see it though?
I see Lauren and Kay. Uh-oh, there he went away.
Let's just let him turn on the live stream and mute it so he can see us that way, and then talk to us on this.
Perfect with me.
Okay. That way we can get started.
Good. I don't have to see everybody as long as y'all can see me.
All right, are you guys ready? Dr. Henderson?
Yes.
Okay, so don't have a gavel, but September 10th, 2020 Dental Practice Committee meeting of the Texas State Board of Dental Examiners will now come to order. The time is 12:44. So by the way, if you're on a device, make sure it's muted until it's your time to speak. Also say your name before your verbal vote during the voting process to ensure proper count. And I will try to announce the names of our 2 other board members when addressing Dr. Henderson or Dr. Tillman, especially on first and second motions. The announcement is, I want to read the mission of the Texas State Board of Dental Examiners, as is our custom. The mission is to protect the public health and safety and to promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related information services to licensees and their patients. So if I can have Ms. Nichols take roll for us, please.
Sure. Dr. David Tillman?
Here.
Mr. Roger Bustamante? I think he's absent. Dr. Brian Henderson?
Present.
Miss Lori Jones? He is not here. And Dr. David Yu?
Present.
All right.
Thank you.
Thank you.
We have a very close quorum. Thank you, Ms. Nichols. The first item on our agenda is the proposed rule from June 5th board meeting, Texas Administrative Code 102.1. And if Ms. Nichols can kind of give us a background on this.
Sure.
Please.
So, excuse me, this amendment was proposed at our June 5th, 2020 board meeting and published in the July 24th issue of the Texas Register. If approved, it will be up for adoption. We received no comments on this rule, and it updates some of our fees, which I can go over really briefly, as it pertains to patient protection and the Texas.gov internet portal. It will also reduce the fee collected for our prescription monitoring program. It will add a late fee for the nitrous oxide monitoring fee and remove the nitrous oxide monitoring fee duplicate certificate fee, pardon me. And it will increase the fee for peer assistance, the maximum allowed under section 467.0041 of the Texas Health and Safety Code, and also remove that fee from rule.
Okay, do we have any comments or a motion for this? Well, I just wanted to keep him, refer back to the June 4th meeting. we originally had the anesthesia fee, jurisprudence fee, and the regular jurisprudence fee as separate items, both at $54. But in that meeting, we agreed that the anesthesia fee should be part of the jurisprudence. So that was eliminated from this updated fee schedule. And also to fulfill HB 3201, the dental, there was an increase in fees from that from a while ago, from $110 for the renewals, because of part of that House bill with the dental the DRP provisions. And also PMP was increased from 10 to 15, and peer assistance from 7 to 10, modest increase. And credit to our board staff, because we kept the governor's request to keep our fee averages to around that 75% of the national average. So, and we're pretty much in alignment with that. So I don't see any issues with any of the fees myself. But any comments or questions from the committee members?
So are you looking for a motion to accept?
If we're ready.
Oh, I'm sorry.
Dr. Henderson, did you have a question?
Yeah, well, I just wanted to verify with Ms. Nichols that there were no written comments to anything that was published in the register.
That's correct. We received no comments.
Thank you. I would make a motion to approve the rule that was published on July 24th, 2020 regarding the fees, and I don't have that number in front of me.
And I'll second that.
Oh, so that's 102.1.
102.1. Yes, thank you. It is Rule 102.1 that was published on July 24th, 2020 in the Texas Register.
Okay, and all in favor?
Aye.
Aye.
It's
right.
unanimous. Thank
Passed
you.
unanimously. Thank you.
Okay, moving on. I'd like Ms. Nichols to also lead discussion on our introduced amendment to 111.5, the electronic prescribing waivers, please.
Yes, thank you, Dr. Yu. So this rule was initially proposed at our June 5th meeting, but after it was submitted to the governor's office for review, they asked that we elaborate on section A1 related to the economic hardship portion of the rule. And we were referred to the pharmacy board's waiver rule, which was proposed at their August meeting. So this language that you see added what mimics the language from the pharmacy board's rule. The specific verbiage that was added states that what flushes out the economic hardship to state that any situational factors affecting either the cost of compliance or the ability to comply, the likely impact of compliance on profitability or viability, and the availability of measures that would mitigate the economic impact of compliance. So I offer up this rule for proposal with the amended changes.
Any discussion, committee members?
So I'll move for the proposal. Move for the proposal.
Great. Well, I just wanted to make one comment that, so the new proposed amendment, was that cleared yet with the governor's office, or this is just kind of what the pharmacy board did?
They requested that we mimic the language from the pharmacy board.
So we have a proposal, a motion to approve a proposal, but don't have a second.
I will second that so we can discuss. Thank you, Doctor.
Okay. Thank you. So any other, all in favor, we're in favor.
Well, I'm in favor.
Thank you.
Dr. Henderson.
I think we're unanimous on that.
Okay.
It was unanimous, I guess.
Okay. So was to move forward with the rule as proposed, and that was unanimous, correct?
Yes, thank
All right.
you.
All right, great. Thank you.
Okay, so next on the agenda is the discussion and possible committee action on dental professionals performing the COVID-19 testing. So Ms. Nichols, would you like to lead discussion on this, please?
Sure. So at the June board meeting, the board recommended that this topic be placed on the Dental Review Committee agenda at the request of Dr. Marshall Goldberg. He brought this issue to the board's attention and submitted documentation for the board's review. This has been an evolving topic. It was TSBDE staff's recommendation initially that dentists not perform COVID testing for a number of reasons. One, initially testing had to be ordered by a physician. Two, the number of tests and availability, especially at the beginning of the COVID pandemic. And three, the ADA issued guidance recommending that dentists not test until ADA was able to receive further guidance from federal healthcare agencies, such as Health and Human Services. Now it appears that we are on the verge of reliable and accessible testing. So the dialogue has changed a little bit since the beginning of the year. In October, the ADA is having a virtual house meeting to discuss COVID testing. So this topic is probably a little premature for our board to make any decisions on. This is really informational only. I would like to say that the ADA does not consider COVID-19 testing to be a scope of practice issue, and that dentists are expected to routinely screen for high blood pressure, smoking habits, blood sugars, that sort of thing. And the test is also not diagnostic in a dental office since the dentist is not treating COVID-19 illness. So at this point, we don't believe it would be a scope of practice issue. Rather, that licensed dentists to be eligible to administer COVID-19 testing must be able to first certify with a federal lab. That is a requirement. They need a certificate of waiver from the Centers for Medicare and Medicaid Services, just like physicians do. And they may need a certificate to administer FDA waived COVID-19 diagnostic testing as well. So it's really in the best, the reason our advice to licensees and stakeholders is to refrain from COVID-19 testing is that we don't want anybody to get in trouble because they're not meeting the federal or even state regulatory guidelines. I've also did some reading, and there's another approval process you have to go through at which the governor is requiring through dishes. So we just want to make sure that before we give everybody the green light to start administering tests, that they understand what's necessary and what regulations they need to meet outside of dental board regulations in order to be an approved COVID-19 tester.
And I'd like to thank Ms. Nichols for all your research on this. I know it's there's a lot of layers to this. And you know, a lot of it, you're right, is the CLIA certification waiver, clinical lab improvement amendments, and you know, obviously we don't know day to day even what's to become of, you know, whether it's vaccinations, new tests coming out, you know, what our direction from the governor's office or the legislators, we just don't have a lot of information right now. And my recommendation is just to not make a motion on this simply because this is such a dynamic, changing environment that, you know, unless we get direction from legislators or the governor, then, you know, or even the federal guidelines, it doesn't seem, you know, a good idea to do anything at this point with this. Any comments from our committee members?
Dr. Yu?
Yes, sir.
This is Brian Henderson. Ms. Nichols, I just wanted to verify, you have not run this through the governor's office with his edicts that he has specifically for Texas COVID tests. Is that my understanding?
That's correct.
Yeah. So I agree with you, Dr. Yu, that there's a significant amount of work that has been done by Ms. Nichols on this situation, and it would be my advice to have dentists to consider if they need testing on their patients. There's plenty of tests available now around physicians, and that would just be a level of responsibility and liability that they may not want to try to undertake, even if it is worked out to the various states. So that would be my opinion as well, Doctor. Thank you.
And I agree, Tillman.
Great. All right, so no motion on that. And are there any public announcements that we have?
We have no one signed up for public comments.
Okay. And okay, so other than that, any motion to adjourn?
Well, I do have a quick motion or a comment on the comment part. I was going to ask Ms. Nichols if before, in the interim, if she could leave me connected so I could figure this out so I could see everybody for the next meeting. But I would make a motion to adjourn.
Do I have a second?
Okay, you figured out.
Dr. Tillman, do I have a second?
Yes, you do.
All
Thank you.
right, all in favor?
Aye.
I think it's unanimous.
Motion, I'm second. We just kind of flip-flop.
Okay. Thank you, committee. Appreciate you.
Thank you. Thank you.
Good job.
Thank you.
Worked hard. 15 minutes.
So let's help Dr. Henderson really quick. That's fine.
We can help him live.
Well, the live stream won't stop though. He's been putting out
Casey, do you just want us to stay on since we're next?
So we're gonna put up a be back later sign as soon as we get Dr. Henderson, because the streaming is gonna stay on. So right now it's still streaming.
You can stop your video.
But you can stop your video.
Oh, okay, great. Thank you.
So, I just wanted to run this through the IT. Every time Dr. Yu talked, I could see him. But when anybody at the agency talked, it just says TSBDE live stream and no picture of any of you all.
It's a plot.
Yeah, that's correct, because the live stream is one.
That's 12:58. Thank you. Yes.
So, how do I get off this live stream by any chance?
All right, hold on one second. Okay. All right, I'm gonna use Tillman's, that way I don't mess with.
Do we need to change the sign?
He's gonna come help you.
We'll resume at approximately 2 o'clock.
Okay. So it should be what we were talking about in the top right-hand corner. Yeah. You don't see anything saying.
It'll be more than 10 minutes, but that's
So, is this Dan?
No, Chris.
Chris, give me your cell number and I'll take a picture of what I'm seeing.
I'll email you my cell phone number because I don't want my phone number to be even on the live stream.
Okay.
I can't without it breaking the live stream and everything else. That's why I was saying we maybe.
Hey, Chris?
Yes.
What if, because I know Casey has my cell.
Yeah.
She can give you my number.
Okay.
And just text me something and I'll send you a picture of what I'm seeing.
Okay, we'll do.
All right, so for now, just if you can, you stop your video, Dr. Henderson.
Stop the video?
Yeah,
Okay.
at the bottom left-hand corner.
Yeah, he knows where that part is.
Yeah.
Hey, Cassie, you can.
Yeah.
Oh, cool. I guess I should do that.
2 o'clock?
2 o'clock.
Short and sweet.
Thanks.
Anesthesia. Yeah, anesthesia should be short.
Yeah,
and
we
sweet,
can
too.
mute it now.
And you were gonna do the blurb about, yeah, do the free, the first one, yeah.
Everyone can unmute themselves.
We can go ahead and unmute everybody. And we'll get this thing going.
Shall we start the meeting?
Dr. Henderson, do you see the gallery view now?
I do.
Okay.
Thank
Wow.
you so much for the help. I mean, it's amazing.
Smiling faces.
Yes.
Good.
Okay. I think we're all here and ready.
McNeil, Tillman, Burke. All right, we got you all.
Okay. The September 10th, 2020 Anesthesia Committee meeting of the Texas State Board of Dental Examiners will now come to order. I want to remind board members, please, if you're listening on devices, have them muted until it's your turn to speak. Say your name or any verbal motions or voting to ensure proper counting to help us with our minutes. And I will do my best to announce your name so that it will be followed on the minutes. I want to welcome Ms. Nichols as our new executive director in our committee and to our agency. And congratulations, Ms. Stoddard, to General Counsel, and of course, Ms. Camp as assistant. So welcome and congratulations to all of you. The mission of the Texas State Board of Dental Examiners is to protect the public health and safety and promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related information services to licensees and their patients. Ms. Nichols, would you please call roll?
Yes, sir. Dr. David Tillman.
Here.
Dr. Linda Burke.
Here.
Dr. David Yu.
Present.
Dr. Robert McNeil.
Present.
And Dr. Brian Henderson.
Present. Thank you, Ms. Nichols.
Yes.
Ms. Nichols, would you please lead discussion on the committee action on request for exemption to board rules for 2020-01074? And I'd also like to know if he is present as well.
I am going to turn the floor over to Ms. Studdard, and I do not believe he is present, but we will double check that right now as well.
Okay, thank you.
So committee members, you'll see the application at issue in your materials. The applicant submitted a nitrous oxide permit application.
Oh, it's waiting.
And is requesting an exception to board rule 1.3A1 because the applicant doesn't meet the 14-hour of training that's required under the rule. So you'll see the application as well as staff's timeline of events. And if you have any questions, we're happy to answer those.
Thank you, Ms. Stoddard. Dr. Yu, you have a question?
Hey, I just wanted to ask licensing or Lee whether this this licensee has a level 3. You know, because I know she did a GPR and any other form of sedation that this licensee has.
This is Lee, anesthesia permit specialist. For this particular licensee in the state of Texas, she does not have any permits. She has stated that in multiple other states that she's had permits such as California, Nevada, New Mexico, and North Dakota, or some of those states didn't require them. When I did a little research into those states, I found that California, Nevada, and New Mexico, I could confirm. But then when I looked at North Dakota, she has a license there, and she also has an application that has been pending for nitrous for quite some time, since February 2019, that's still pending, that has not been approved. And based on their requirements in that state, it's the same as ours. So they're pending that letter that we need stating that she's met the minimum requirements of 14 hours trained. She did complete a GPR with the VA. They did send us a letter. And if you notice in the write-up and in the letter and in the email, they cannot confirm the amount of hours trained with nitrous. And then she also graduated from the University of San Francisco. And they sent a letter stating that she completed training in nitrous, but they could not verify the amount of hours either.
So Lee, is it normal for program directors to specify how many hours the graduate completed of nitrous?
Yes, sir. Yes,
Oh, it
sir.
is normal. Okay.
Definitely.
Yeah, because personally, when looking through the information, I mean, she obviously has a letter from UCSF, saying that she passed nitrous, and then a GPR from the VA with proof of completion with nitrous experience, and then did 12 years using nitrous in different states. And her issue is that all the courses, hands-on courses, are postponed because of COVID, so she can't get those the CE requirements done at this point. But I just I didn't know her level of sedation, especially
Yes.
graduating from a GPR, but it sounds like she doesn't have any other sedation levels.
No, sir, not in the state of Texas. Now, I did do some research as far as other courses available within the state of Texas and other areas to be able to complete a nitrous course. And there are some out there and have been some. Now, understand that this application is from January of this year.
Yeah.
And we went from January to August is the next time I heard from her.
Thank you.
And that's when it was stated that due to COVID, we couldn't find any courses out there. But I found several of them out there. At any rate.
Thank you, Lee. Any other committee members have any comments? So I would speak against requesting his exemption. There's a nitrous course in Houston tomorrow that he could sign up for. And there's another one that may be happening in October in McKinney. So there are plenty of nitrous courses that would verify his educational experience, just to fill the committee. There are many courses and rotations through anesthesia that may or may not meet the criteria that we have for a nitrous permit. And just because someone does a GPR and has a rotation in anesthesia somewhere, and they're not willing to say how many hours or how many cases and what kind of education they got, then it could be just an observation and not an administration. Therefore, I would speak against, until this person can prove better education, I would speak in denial. Any other?
I make a motion to deny the request.
Thank you, Dr. Yu made a motion to deny the request. Is there a second? Dr. Burke?
I second.
Second. Any further discussion?
I can confirm, Dr. Henderson, that she is not called in to participate.
Thank you. Thank you. So seeing no further discussion, call the question. All in favor, please do so by your name as yes or no. Dr. Burke?
No, I mean, I agree to not grant her the.
So you're in favor of the motion?
Permit. Yes, I'm in favor. Yes, in favor.
Dr. Yu?
In favor.
Dr. McNeil?
Yes, McNeil.
Dr. Tillman?
Favor.
Dr. Henderson? In favor. Motion passes unanimously. Thank you, committee. Ms. Nichols, would you like to please lead our discussion on committee action on the proposed rules from June 5th, 2020 board meeting of rule number 110.2 sedation anesthesia permit, published July 24th, 2020 in the Texas Register?
Yes, sir. So this amendment requires applicants to complete an anesthesia jurisprudence assessment prior to obtaining a sedation anesthesia permit. This rule was proposed to comply with the requirements set forth in the Occupations Code 258.1551. Like you said, it was published in the July 24th, 2020 issue of the Texas Register, and the board received no written comments regarding this amendment.
Thank you, Ms. Nichols. So no public comments currently as well today?
Correct.
Thank you. Committee, do we have a motion or discussion to propose this as published in July 24th of 2020?
I mean, to
So
adopt.
moved, McNeil.
Second to adopt.
Dr. McNeil, second by Dr. Tillman. Roll call in favor or against? Dr. Burke.
In favor.
You're gonna have discussion? Point of clarification.
Thank you.
Ms. Nichols, did you have something you were going to say about this?
I just wanted to make sure you knew that it was a motion to adopt. It's already been proposed. Thank you.
Thank you. Sorry.
And to give us just a little bit of background, this just ties up the issue of what we needed to do per other existing rules.
Correct. Per
Perfect.
the DPA, yes.
Yes, I think this is the completion of our sunset legislative rules of anesthesia. Thank you, Dr. McNeil. Is there any further discussion by the committee that would like to discuss this? Seeing none, back to roll call in favor of adopting the permit of the rule at 110.2 as published July 24, 2020. Motion was made by Dr. McNeil, seconded by Dr. Tillman. Dr. Burke.
In favor.
Dr. McNeil.
McNeil in favor.
Dr. Tillman.
Favor.
Dr. Yu.
Approve.
Dr. Henderson in favor. Thank you, committee. It passes unanimously. Ms. Nichols, would you please lead discussion of the currently proposed rule from July 5th, 2020, of the board meeting of our rule 110.9, anesthesia permit renewal, published July 24th, 2020. Thank you, Ms. Nichols.
Yes, sir. So this amendment would require permit holders to complete the anesthesia jurisprudence assessment once every 5 years. This rule is being proposed again to comply with the requirements set forth in 258.1552. This amendment, like you stated, was published in the July 24th issue of the Texas Register. The board received no written comments regarding this amendment. Initially, the board had requested that we track the 4-year jurisprudence renewal requirement found in Rule 104.13, but this was not approved by the governor's office based on the 5-year cycle requirement found in 258.1551, which the board was fully aware of when we had this discussion at the board meeting. So the rule as proposed in the register does have the 5-year requirement.
Thank you, Ms. Nichols. And I assume there's no public comments today for this? Thank
Right.
you. So, Ms. Nichols, help me understand as I read this rule as we are at the 5-year mark. If you have an anesthesia permit, your jurisprudence requirement becomes a 5-year requirement, not a 4-year.
Correct. So the way the board will handle this is that if you are a licensed dentist with no permits, no anesthesia permits, you will take your jurisprudence exam every 4 years. You'll get an update. I believe that currently licensees get an update when it's, or some type of notification when it's time for them to take their jurisprudence exam. For all of our licensees that hold a permit, what we're able to do with the vendor we use for this exam is we will wrap your regular jurisprudence and your anesthesia jurisprudence into one exam. So you will certify what your anesthesia level is when you log in to take the exam. Say that you're an anesthesia 2 permit holder, then you will certify that. You'll be given questions to that level of expertise, and the rest of the questions will be your regular jurisprudence exam.
Thank you, Ms. Nichols. Committee members, would you like to have a motion to adopt and a second so we can have discussion?
So moved, McNeil.
Dr. McNeil.
A second.
Dr. Yu, second. Any discussion? Dr. McNeil.
So I like the general flavor of how this is going and just making it easier for the licensees. And I think that was certainly our intent, because it gets so complicated to keep up with the requirements, and especially as we get into the opioid issue as well. So fully in agreement.
Dr. Yu.
And this will complete our SB 313, correct? Thank you.
Someone
Dr.
muted Dr. Henderson, which I've tried to do that multiple times myself, but I've not been able to do it. They may have to unmute you.
Okay.
There we go.
Thank you, Dr. McNeil. Dr. McNeil.
Is the test ready to go? Questions formulated.
The rollout is about a month. If Christine is on the line, I believe she and I spoke about this a day or two ago, and the update from the vendor we used for this exam was about a month away. Christine, you can correct me if I'm wrong on that.
The questions have been generated, and it's just a matter of implementing it into the software system.
Exactly.
Okay, and they're true false questions, or it's a
it's mixed. It's
you keep answering until you get the right question or the right answer.
No.
Okay. Just seeing if I can pass it.
Fail the exam.
You can fail the exam.
You can fail the exam.
Okay. Thank you, Christine, for making us worry. So what's the course of action there? If they fail it, do they retake it immediately? Do they have to go through it and re-register? Do we know? Because the jurisprudence itself was, didn't you keep taking the exam until you passed it?
Yep.
Correct.
And so the anesthesia component will be different, that if they pass the regular jurisprudence, non-anesthesia, and then they fail the anesthesia component, they'll have to retake the entire exam?
So it's going to be incorporated into one exam, right? So it's not going to be a dentist and then anesthesia. It'll be one exam, which includes a mixture of questions related to your level or your license type. And the idea is that, yes, you will be able to fail this exam. And I'm looking at 100% pass. So you're not going to be able to slide by with a 70 or 75. And
Wow.
you'll fail it. If you fail it, then there'll be a timeout and then you get another chance. If you fail it again, you're going to have to retake.
Okay, and so the non-anesthesia component, and it's been a while since I took that component, it's 100% as well?
Currently, it's no, you can't fail it. But yes, it will also be 100% across the board for all license types.
Okay, do we see this as being a potential problem?
No.
Have you ever taken a test and not got 100% on it?
Oh yeah.
I never have, so. I don't think I've ever gotten 100%. So realistically, I'm just trying to talk through the logistics on this, and maybe you guys have sorted that out on the back end. But if you have 30 questions and you get one wrong, I just want to know how we want people to know the information, certainly, and how we're just going to make this efficient and make it happen.
Well, this is your time. I mean, I can definitely work with Ms. Nichols and Ms. Studdard.
Is there a beta test? Maybe having someone like Dr. David Yu take the test first and see how it goes.
I would fail.
But realistically, maybe before the rollout, certainly doing a beta test may not be bad, and you probably intended to do that anyways.
Yeah, we'll work on the logistics of that internally.
Thank you.
Okay.
Thank you, Dr. McNeil. Good points. Ms. Mendez, I have a question just that Dr. McNeil kind of brought up regarding the people who don't have an anesthesia permit and they take their jurisprudence. You're going to leave that exam where they must pass or they can pass with one, and that's not going to be reconfigured to be a failure like the anesthesia permit people?
My plan was to make it the same, Dr. Henderson, across the board.
Yeah, thank you. I just want, it appeared that it was going to continue in the current process of where someone who paid is automatically going to get their educational certificate for jurisprudence. But if you had an anesthesia permit, you could fail it, but you couldn't fail it if you didn't. I just wanted to make sure that was clear, that the intent of the agency was to make them both where you could fail them.
Correct. That's my intention.
Yeah, that's kind of what I thought we were at, and I wasn't sure that was clear with Dr. McNeil.
Well, it's clear. I'm just not sure it's a good intention. You know, realistically, I'm back doing my MBA right now. If I get a 28 out of 30, I think I'm doing bang on.
So how many times can they take it until they pass?
Twice.
Right now we're looking at 2.
And if they can't pass it after 2, they'll lose their license?
No, they're gonna have to repay.
Okay.
They just have to repay.
I see.
Repay and retake.
Yes.
Repay and repay.
Is there a
Dr. McNeil?
Is there an informational sheet or booklet that goes out to people, or are we just saying go to the site and look at the anesthesia rules? Is there a prep sheet?
Well, Dr. McNeil, I'm pretty sure the rules are published on our website and people can sit there and read them. But Ms. Nichols?
Right, we don't have a prep sheet to send people, but our rules are available on the website. What I was going to say, and Christine, please correct me if I'm wrong, is I believe if you fail or if you don't get 100, I believe the test tells you the questions you got wrong.
Right.
Okay.
Correct. That's the intent.
The intent is we want people just to know the information.
Right.
And I just wanted to re-clarify, 70 was passing.
We can discuss. I'm not sure 70 is okay.
Well, I know there was no written comments. I did get a few phone calls over this from permit holders thinking they weren't necessarily going to be responsible for permit levels that were higher than their own, but in reality, there is some crossover. So I'm sure the agency is going to take that into consideration, but mostly my understanding, it's going to be based on your permit level. Is that correct?
That's correct. It's based on your permit level.
Thank you. Because you would, if you had a level 3, you'd have to know you couldn't use certain drugs for a level 4, but that would have to be a question. I mean, there are a lot of those same crossovers and all the permits as we have restrictions in them all. Any further discussion? So what is the pass rate percentage? Is it must be 100?
100.
100 sounds good.
Well, if it's and to second Dr. McNeil's point, if it's 100, it better be darn easy, because it's otherwise we're going to have people keep having to retake it over and over. But until we actually see or beta test the questions, it's just hard to tell if that's a reasonable thing to do.
And do we anticipate how many questions there would be for that 100?
Not at this time.
Okay.
Dr. Henderson, ¿quieres saber todo?
Any further discussion, committee members? So we have a motion on the floor to adopt 110.9 as proposed and published in the Register on July 24th, 2020. Roll call vote. Dr. Yu.
Yes.
Dr. Burke.
In favor.
Dr. McNeil.
In favor.
Dr. Tillman.
In favor.
Dr. Henderson, in favor as well. Thank you. Committee passes unanimously. Ms. Nichols, would you please lead us on a possible committee action on pre-medicating patients with anxiolytic or sedative drugs prior to treatment?
Yes, thank you, Dr. Henderson. So this topic was added to the agenda based on some feedback or some discussions that were had during an informal settlement conference. This seems to be, I don't want to say a trend, but we see this, and we see instances of this happening. And so I believe Dr. McNeil was the one who suggested that we add this to our agenda for discussion. So I'll open up the floor to our committee for discussion.
Thank you, Ms. Nichols. I'm going to call on Dr. McNeil to kind of inform the committee what you're thinking, what stimulated this topic for you.
Thank you, Dr. Henderson. Mostly just through various ISCs, we have people that are prescribing Halcyon either with a prescription or somehow having the patient take it beforehand. They do not have level 1 sedation permits, and they basically say they're giving it for anxiolysis. And the challenge that I have is that level 1 permit holders that utilize Halcyon, and obviously that's one of the more common level 1 single agent drugs that's utilized, they have to fulfill various obligations as far as dispensing and monitoring the patient per our rules. And it looks as though people are circumventing that by calling it anxiolysis.
Thank you, Dr. McNeil. Just a point of information, you kind of threw out our next agenda topic item on whether someone should have a level 1 permit. Should we keep that separate for discussion and just talk about the action on pre-medicating patients with anxiolytic or sedative drugs prior to treatment? And it was my understanding from Ms. Nichols that it was really based on should we consider rule adoptions for medicating patients outside of the office. I think is what this agenda topic was meant. Is that misspoken, Dr. McNeil?
I'm agreeable, and certainly there's some overlap here. But if you want to look at just the general approach of anxiolysis versus out of the office, then let's have that discussion.
Well, I think that's the way the topic is written, is anxiolysis out of the office versus sedative drugs prior to treatment out of the office.
Sure.
Or in the office is the way I interpret this. And certainly I would speak to any anxiolytic drug that a normal physician or someone who would be treating an anxiety type situation on a daily basis, unmonitored, in that therapeutic dose range would certainly be acceptable for a dentist to give the same drug, same dose, same recommendation. It's when we start giving, a 0.5 milligram of Halcyon outside of the office. I know the AAPD has some guidelines where they do not want children sedated outside of the office. And I think the question is, are we looking at trying to put that into our rules? Because our rules specifically say you should follow the APD guideline, but we don't have a rule that says you must, nor do we have it for adult patients as well. Is that true, Dr. McNeil?
I believe so.
Okay. Committee members, does anybody else have any comments or thoughts on just that topic? Dr. Yu?
Well, I just wanted to ask Dr. Bell or Mr. Lannon whether there have been, issues of administering oral sedatives and having issues with it outside the dental office that they've seen.
Should I go?
Yes, please.
I can say that more than anything, it's just a confusing issue for DRP to deal with. I don't know that I've seen any patient harm done, but it's more confusing for the investigation and the DRP members. What is anxiolysis? I mean, sedation's a continuum anyway. And so where does anxiolysis end and level 1 begin? For me, it's the addition of nitrous, unless the dosage is just very gross, just way over the top. But as over the top than you would give for a regular level 1 sedation. But I agree, it would be wonderful if we could have some more clear guidance in rule around that topic, it would be helpful.
So you haven't seen standard of care violations, or patient harm when the dentist has the patient take oral sedatives like an hour before getting into the office?
Well, I mean, I wouldn't say never ever. I would say it's certainly not common. I would need to do a, look through those cases, and we could probably do a query that could bring them to the top, and I could look a little closer at that. I would say that, I mean, I do not think it's a patient safety issue. It's just the driving while on the medications is a little bit more of an issue because, again, we don't have very clear and strict rules surrounding that. If they give them Valium the night before with a half-life, if they give them nitrous during the clinical appointment, is that then level 1 sedation because the Valium would still be active? Things like that are what we deal with. But no, I would say, and again, perhaps there haven't been violations because it's just kind of this gray area.
Yeah, thank you.
Thank you, Dr. Bell. Dr. McNeil, you wanted to add something?
Right. There was a case I was involved in some capacity. And I can't remember if it was as an employee, but a fairly high dose of Valium, 20 milligrams given outside of the office. And the patient had a cardiac event. It was a question whether it happened in the hallway in the reception area versus being in the operatory itself. And it was sort of hard to pin down. And I'm fully agreeable with what Dr. Bell said, that it does cause confusing things for the DRP members because we don't have that clarification. Now, if you look at it strictly from a legal liability risk, as a prescribing dentist, if you prescribe a drug, you certainly have the risk that they drive themselves to the office, get in a motor vehicle accident. You can make a great case just from a liability protection standpoint that that's not a prudent and appropriate thing to do. I guess for us as a board, we're seeing people go through, we look at this, is this a loophole? And if people are going to be able to prescribe anxiolytics, then do we get away with the level 1 permit and just say everybody go ahead and do that? Because it seems ridiculous that one person has to have a level 1 and document and others don't.
Thank you, Dr. McNeil, because as we know in statute, every dentist has the anxiolytic authority. And the question becomes, where does an anxiolysis dose end and a sedative dose begin? And that would take some discussion. I would like to ask Dr. Burke what her feelings are about at least sedating children outside of the office.
Well, my feelings are typically most pediatric dentists don't sedate children out of the office. But when I think about adults, there are so many adults that live day to day taking anxiolytic medication, for their stress or whatever it might be. But I think Dr. McNeil just made a great point that maybe it would be best to just make it standard that everybody does have a level 1, because there's such a fine line between when you're level 1 and when you bump up into using it as a sedative agent. But as far as children, our preference is to sedate in the office once they arrive so that we get all their vitals and do a complete assessment, make sure that they have a great NPO status. But as far as adults, I think it might be more difficult because I'm assuming that there are probably several patients that day to day take anxiolytic medication as part of their daily drug regime.
Thank you, Dr. Burke. And so I can see where this conversation is kind of leading also as the level 1 permit. So I'm going to just go ahead and take the chair liberty to say we're adding that agenda item for discussion, which is, should prescriber have a level 1 anesthesia permit? So I'm going to pitch this to the committee for consideration. Should someone who administers or prescribes Halcyon, should that provider have a level 1 because it is not considered an anxiolytic? So I'm going to throw that out for discussion. Anybody? Dr. Yu?
Well, and I would second what pretty much everyone said. I think in the course of, we have, for me, when I do oral sedation, I have patients come in an hour early, and have the escort, sit next to the patient under a pulse ox and blood pressure checks. But the problem is that what is appropriate, because when patients take, let's say, 0.25 or 0.125 milligrams of, let's say, halcyon. I mean, we all know that benzos in general have a high therapeutic index. And, but the problem is that when you're taking it for anxiolysis on the way to dental offices, the recommended dose for elderly is 0.125. So, are you going to consider the age of the patient or whether the patient's at high risk before having the patient take it, going into the office? So there's so many different, because you have to customize the dose based on the patient and the situation. And I know a lot of practitioners, I don't know, I do not know the statistics, but I'm assuming a lot of them have the patient take it, an hour before coming in even, because otherwise you're just letting them sit there an hour and then having to maybe dose them again during that hour. And then by the time they finish the procedure, then that's when they head home and they're even more sedated. So I think logistically, a lot of dentists do that just so they can get the second dose in if the patient needs it. Because we all know that the onset is, around an hour for halcyon. And, so I see the issues with it, which is why I prefer IV sedation, because you could titrate, you can reverse and all that. So, yeah, and I agree that there's a very gray zone between zero license and level 1 license. Because level 1, you could technically, do the same thing as 0. So that's my issue with it.
Thank you, Dr. Yu. Just to give the committee, when the level 1 permit was created, it by the American Society of Anesthesiology, it was considered anxiolysis. But because Texas already had anxiolysis in their statute, they couldn't say you must have now some kind of education to get a level 1. At one time, it was oral sedation was something more than anxiolysis. And that's just a little history on where we came from with a level 1 versus anxiolysis. And I would like to speak, I have stopped sedating all of my patients outside of the office orally. I used to be a regular, look, that was a standard of care when I graduated. You loaded people up the night before to help them sleep, and then they took pills when they came to your office. And when we started saying we had to take preoperative blood pressures, and when that rule was passed, that's when I stopped. And so for all of this discussion about whether a patient should or shouldn't be sedated outside, even anxiolysis, if they are giving that outside of the office, I personally think they could be below standard of care if you look at our rules in a strict interpretation. That's not to say that doesn't happen. Look, I did a lot of special needs patients that wouldn't get out of the car unless you medicated them before they even got in the car. And the last place you wanted to do is try to keep them somewhere in your office corralled, trying to wait for that oral sedation to kick in. So special needs dentistry and certain indications might need to be considered as an exception. It's just as we go down this road, it becomes a slippery slope for a lot of our licensees and the various patients they all see, whether they're elderly or young, or they're old or special needs, et cetera. So I'm just pitching that out to the committee as we're sitting here contemplating this discussion. I do think it's an important discussion, but where we go from here, we'll see. Dr. McNeil.
And to back, as David Yu was talking, Dr. Yu, you know, we expect people, if they're having a procedure performed with nitrous oxide, that we've got to go through a preoperative checklist before we start the nitrous oxide. And here we're looking at using a sedative drug at home, and we're certainly not going to their home to go through the checklist. And so we can all kind of look at it and say, you know, on a good practice, prudent standpoint, none of this makes sense. Now, the law of unintended consequences, let's say we carve out and say, Halcyon is not a drug that we believe should be given outside the office, the dental office. Is that going to have other agents be a problem? Are we going to see people do higher dosages of Valium with that? Or is that just something that we have to accept and be mindful of? I don't know.
Thank you, Dr. Mino, because you're exactly right. Now let's just choose Valium as a drug dose. There are plenty of studies or drug doses published that say this is a sedative dose, this is an anxiolytic dose. And so we kind of already have some of those guidelines, and it's easy for a practitioner to do that without us necessarily reinventing that wheel, because physicians use that same anxiolytic versus sedative drug dose. So the stack dosing that Dr. Yu brought up are kind of an important issue. A lot of people try to give this the night before and then see them early in the morning where that drug is still working. And as you see through our rules, a level 1, when does a level 1 become a level 2? Well, that 1.5 MRD and maximum drug dose. And so they can stack it as long as it's fully absorbed by our rules, but they're stacking them because they're waiting for a higher potential action. So that too is a potential problem. Dr. Yu, you had something you wanted to say.
Well, and it's not, thanks, Dr. Henderson. It's not written in our rules, but, you know, I would really like to see that oral sedatives administered outside the dental office can only be at anxiolytic doses. You know what I mean? Which is definitely below MRD. And my ideal, honestly, is to do away with, to do any kind of oral sedation, you need to have a level 1. I mean, that'd be ideal because, you know, the whole pre-op checklist, the training, I mean, they need to be able to manage emergencies. And, you know, when you don't have a sedation level, then you don't have any of that training other than CPR.
Thank you, Dr. Yu. So is it my understanding you would like for the committee to consider what is an anxiolytic dose and drugs that are acceptable to be given by a licensee who doesn't have a level 1 permit, and any licensed dentist can give that dose, and anything more than that must be given in the office. And if you give more than that, you must have at least a level 1 or a level 2 or a level 3 or a level 4 permit?
Well, I don't know if we need to make a motion for that, but what if we just have the public comment on any of that, like TDA?
I think you'll get a lot of public comments on all this discussion, but in order for us to have some kind of, unless we make this a working anesthesia committee meeting where we have a stakeholder meeting and input just on the topic in itself. And so I might defer this to Ms. Nichols if this is something that we think that's a better route than trying to write some kind of rule in our deal. And I think we'd have to put it in standard of care. So technically it might have to come out of David Yu's committee because it would apply to all licensed dentists and not necessarily anesthesia permit holders. But Ms. Nichols, do you have any thoughts on this?
I do think a stakeholder meeting would be beneficial in that situation.
Thank you. Committee members, do you all have any further things you would like to add, or we want to make a motion that we give the agency to have a stakeholder meeting when the pandemic ends and we can have a full meeting, or do we want to push this and have it as a Zoom meeting setup that they have virtually? Ms. Nichols, do you have a thought on that?
It's at the committee's discretion. I mean, Zoom seems to be working fine, but if you'd rather wait until we can gather again to have people come in person, that it's your discretion.
Thank you. Dr.
I,
McNeil?
oh, go ahead. Go ahead, Bob.
Are we on that second item yet? Can we talk about Halcyon?
We kind of put them both together.
Because an easy play here is to say that you have to have a level 1 permit to dispense and utilize Halcyon for your patients, and it has to be given in the office. And don't touch the anxiolysis component. And whether that has to be a rule, whether that has to be something that's put out there in some of our board information.
So Dr. McNeil, I mean, it's not to speak against, we were also talking about drugs that have both sedative and anxiolytic property. Halcyon certainly is not an anxiolytic anywhere in any drug formulary that you can find. It's only a sedative. Therefore, I don't think it's an anxiolytic either. But
and that was our big problem, though.
Yeah, but Valium could be. And so when does a 10 milligram dose or a 20 milligram dose, depending on the situation of the patient, might become a sedative dose, not an anxiolytic dose. And so if we're going to bring this up as a rule, we ought to go ahead and try to clarify and anticipate any kind of other problems that are going to develop. That's all I would mention to that. Dr. Yu, you have something you would like to add?
I really think it should go to the anesthesia committee because I mean, that's their job, honestly, because they can look at, data pulled and see if this is really an issue and make recommendations about safety.
Thank you, Dr. Yu. So does the committee have any kind of motion they would like to come out? Or are we going to let this discussion lie until we meet in December, hopefully in person? Does the agency want to take this upon themselves, Ms. Nichols? Is it such an issue that we need to address this?
Well, if the committee wants us to set up a stakeholder meeting, we'll be happy to do that. I would like some kind of recommendation from the committee, though.
Dr. Yu.
I actually would rather the stakeholders have the meeting after the recommendations from the anesthesia committee. So I'd like to move to refer this to the anesthesia committee, both items.
We are the anesthesia committee. We can.
I'm sorry, the other committee.
What committee is that?
The anesthesia review committee.
Oh, the advisory committee.
Advisory committee. Thank you.
Well,
I thought that's what we were talking about.
Dr. Yu, that is not an appropriate situation for them to review. They review cases in morbidity, mortality.
Right.
Well, they also make recommendations.
They could make recommendation. That is in their statute ability to make a recommendation. But why do we need to wait for them to make a recommendation when we're sitting here talking about it ourselves? And it would come to our committee to handle if they made a recommendation. So this is the appropriate place to have this discussion. Ms. Nichols.
Yeah, just to clarify, the anesthesia advisory committee, like you said, they review trends and they do make a committee report, but this would have to be a situation where they saw some type of trend where they would include this in their report. It's not something where we can send them questions and ask them to opine.
I see. Okay. Well, then I'd be okay with the stakeholder.
And the other question I think is have there been reported adverse events that have caused a question of safety as it relates to this issue? And if not, then the question is what's the motivation for the evaluation? Where does that come from? Why? Because there's always potential of causing unintended consequences, as they say. And I think anytime the board has stepped out, and if there's no true need, you always run the possibility or the potential of causing stirring the pot as well, and legislatively or among stakeholders, when I think you have to ask the question, is it a safety concern for the public? So that would be my only comments.
Thank you, Dr. Tillman. Dr. McNeil, you had something you wanted to say?
You know, I think, and I can appreciate what Dr. Tillman is saying. Getting back to the Halcyon issue, I think it's ridiculous that someone can give it for the patient to take it home and have no need for a permit and no need for appropriate documentation versus if I give it in my office, then I've got to get them on monitors and do all this kind of stuff. So either we look at it and say, Halcyon's not a problem, don't get a level 1 permit, you don't have to do all your vitals every 10 minutes, or we make people give Halcyon in the office. You know, other than that case that I talked about, that high dose of Valium, I haven't personally seen other significant safety issues with the anxiolysis, and maybe anxiolysis is not an issue, but as a board, I don't think we can sit there and have people being able to use the same drug in some different ways and mandate one way one thing and the other way nothing else. So I would move that we look at saying Halcyon as a drug needs to be given in the office and with a level 1 permit, and to follow the rules and regulations that go along with that, and have something like that go out to stakeholders for input.
Dr. Burke, Dr. McNeil, hold on just a second. Dr. Burke, Dr. McNeil, was that a motion?
Yes, it was, sir.
Thank you. Dr. Burke?
I'll second that. I agree.
Any further discussion regarding the motion?
So,
They'll get back to you, Dr. Tillman.
So are we picking on Halcyon only?
And that's our issue with ISCs that we've seen be the issue.
Okay, so
Need to vote.
what's,
Sorry.
no, go ahead. Sorry.
We need you to repeat it. We didn't catch the full
Dr.
version.
McNeil, if you could repeat the motion.
I move that we
Require a level 1 permit.
require a level 1 permit for the utilization of Halcyon, and that it's administered in the office for in-office use only. Thank you, Dr. Burke.
You're welcome.
Thank you.
Dr. Tillman.
So the other issue is, is there an instance when Halcyon could be given as it does not relate to the sedation of a patient? I don't know what other reasons, perhaps there's a nocturnal bruxism or apprehension with a patient as it relates to another dental issue, but not related to a procedure that's impending within the next 24 hours. So those would be just some questions to need to be answered. I'm not precluding this motion or speaking against it. I think there are a lot of questions that need to be answered as it relates to this issue. Thank you.
Dr. Burke.
I would say, following up with what Dr. Tillman just said, there are a lot of other drugs that can be used in that situation for a patient that needs an anxiolytic agent, but not Halcyon. I mean, I would say Halcyon. I feel it should be reserved for use as for patients that come into the office. The doctor has a level 1 permit. They're doing all the documentation, all the pre-op assessment of the patient, and monitoring vital signs throughout. I just don't think Halcyon should be given as a pre-sedative agent myself at home.
Thank you, Dr. Burke. Dr. Yu?
So if a dentist normally does Halcyon and administers prior to dental appointments, they would just switch to Ativan or, Xanax, or, I mean, they would just switch it. Was that kind of the intent?
So that was kind of my point, that, and I haven't spoke. I'm in favor of what Dr. McNeil is saying, but I would like to include doses of other benzodiazepines outside of the anxiolytic doses to only be given inside an office by a level 1. But I didn't make the motion.
And I'm agreeable to that as a friendly amendment. I wanted to open that up to you because I can see your point on that. it makes it more complex, of course.
Much more, but if we're having a stakeholder, you might as well go ahead and see, because Dr. Tillman brings up a good point. Now, I know of no other use for halcyon other than sedation. It's very similar to Rohypnol. It's a great benzodiazepine, but there's no clinically use of it. In fact, halcyon's been removed off the European market because it causes such amnestics. And that's why we in the dental field in the United States like it. The sleep dentistry guys who go around and call themselves sleep dentists, they pop a couple of pills, they stack the halcyon on them, and the patient's just amnestic enough to where they don't remember what's going on. So that's just taking advantage of those really nice attributes in our situation. I do think you have to have some kind of training. So Dr. Tillman, you have something you wanted to say.
And then when you throw in Xanax, I mean, I think we'd all be surprised at the amount of people that are just walking around on Xanax every day. So, I mean, it just makes it very complicated.
Exactly my point. In fact, there is people walking around with Xanax, but they're not taking 2 milligrams a day by their physician. Right. So right. It has to do with dosing. And that's truly what my point is. We know Xanax is a great preoperative and sedative drug also, and it's good for an anxiolytic drug, but there is a dose of which Xanax then becomes a sedative dose, and most of those doses are published. So Dr. McNeil, is that a friendly amendment to your motion? Do we need to vote and talk about the amendment, or is that something you would like to restate?
I would not like to restate it, and I'm open to your friendly amendment.
So to be suggestive, you're wanting to replace the word benzodiazepine as opposed to halcyon or triazolone. Is that accurate?
Basically, yes, sir. Dr. McNeil.
In a point of clarification here, Dr. Henderson, basically, as a committee here, we would be looking at some suggested guidelines of dosages for anxiolysis for various drugs, or we want to put that out to stakeholders to give some recommendations for us to look at.
I think, and taking Dr. Tillman's position to let the stakeholders know that the board is considering going down this avenue, let them try to present evidence of doses and research for their own personal use that they're choosing, so that we can then maybe take something that's not so controversial. Because if we just randomly say benzos outside of whatever published anxiolytic doses can't be used, and if you're medically compromised or an ASA3 or an elderly person, we're going to cut those doses down even further, when we know there's some outlying people that are on high doses of these on a regular basis by their physician, now it gets into a funny situation. But when you start talking about stacking them, so they take them 11:59, and then they take their other one for their anxiolytic dose at 5 a.m. so they can see them at 6, it kind of gets into the situation is that's probably not right, but that's an ethical issue that's hard to write a rule. So I'm just putting this out. Maybe the stakeholders have a better way of handling this politically easy than having us be the hammer. Dr. McNeil.
And in the past, I have mentioned, for instance, and I hate to bring up Canada, of course, but the Royal College of Dental Surgeons of Ontario, they have some pretty specific guidelines for different kinds of drugs and sedation dosages. And that's something we had sort of looked at during the Blue Ribbon panel time. And so there are guidelines out there, and there's board authorities that do give some specific criteria for guidance, with some carve outs, like as you mentioned, Dr. Henderson, for elderly and people in different outliers.
Thank you, Dr. McNeil. I believe you have shared that with the committee before, and I'm sure Dr. Yu has it from the Blue Ribbon panel with you as well. So, Dr. Yu, you have a comment on this?
Well, I just, I like the intent of the board. I would caution against setting out some specific dosage guidelines, because as you know, every patient is different, especially elderly and high risk and pediatric. But, you know, and the reason for me recommending this be sent to the Dental Advisory Committee is because we don't know how wide ranging this issue is. And, you know, I was thinking they could analyze the situation and, you know, kind of look at what the issues are to start with, because I'm a data guy. I like to see data. But again, having it out to the stakeholders, I think that's a good start to things. So I'm in favor.
Well, thank you. So Dr. Yu, I would tell you that the data is generated by the information. If they don't have any cases of death and morbidity, they're not going to have anything to give you. I'm going to tell you that if you have one patient who drives under the influence of a pill that you gave and they kill someone else, and it didn't happen in a dental office, is that enough data for you to try to write a rule and not wait for someone who says they died at home taking their pills? So I know personally of some cases where dentists have medicated patients outside of the office. The patient drove, got involved with the accidents. That's purely one of those things that when I teach students on this, I tell them they need to put on their prescription, do not operate a motor vehicle. So now you've given them some written instructions. Now, I don't know. I have seen a lot of Halcyon called in that don't have that. So I'm not saying, okay, that's a simple way to solve that issue if we're just talking about our patients driving under the influence. But as Dr. McNeil pointed out, it is a liability. Anytime you prescribe a drug to a patient, you're responsible for that drug until the drug is cleared out of the patient's body, whether that's at home or whether it's in your office. So I think this is the appropriate panel to take up this subject rather than wait to see how many people die in order for the committee to bring up something. And like I said, it may be a non-issue. I mean, it's worked this way for 30 years. Nobody wanted to use a pulse oximeter when we finally passed the rule about using a pulse oximeter. So hey, it's worth probably having this discussion at this time. Dr. Tillman?
Call the question.
There's been a motion to call the question. There's a second.
McNeil.
Dr. McNeil, any discussion? All in favor of calling the question?
Aye.
Raise your hand.
That's unanimous.
Being called as unanimous. So the question is, we have on the floor a Halcyon only motion.
I'm sorry. Point of order.
Benzo.
Yes. Dr. Tillman.
We had a friendly amendment to change Halcyon to benzodiazepine. Is that accurate?
I mentioned that. I never had a second.
Oh, okay, fine.
So the motion on the floor is Dr. McNeil's.
Point of order.
Yes, Dr. McNeil.
I actually accepted your friendly amendment to look globally at the anxiolysis issue to send it out to stakeholders. Did I need a second?
Perfect. Thank you. I made that suggestion. I was asked, and then I thought was under the impression that it needed to come as a motion. So if you accepted it, it is correct. So the amendment, Dr. McNeil, would, or the motion as it is read, is we're going to look at all benzodiazepine doses and deciding what is acceptable for out of office versus in office use and doses. Is that correct? Correct.
Yes.
All in favor of the motion, Dr. McNeil? Yes.
In favor?
In favor. Dr. Burke?
In favor.
Dr. Tillman?
Favor.
Dr. Yu?
In favor.
Dr. Henderson? In favor. Passes unanimously. Thank you, committee. Good work, Dr. Good work, Dr. McNeil, for bringing the subject up to us.
From Ms. Richards.
Who seconded McNeil's motion to look at the benzo dosage in and
Dr. Burke?
Oh, no, not on the benzodiazepine.
I seconded it.
Yes.
I made the motion, he accepted it.
Correct.
So it was Dr. Henderson, Dr. McNeil.
Okay, thank you.
Lee?
This is Lee Lannon, the anesthesia specialist. So I just want to say, and then this may help with some of the stuff you're talking about, but I get these questions regularly regarding this same thing about Halcyon, whatever.
probably at least 3 or 4 times a week. And I refer them to the Dental Practice Act, which has the information in there. But I will say, I just got one not more than about 15 minutes ago. It talks about I'm a Texas dental licensee. I don't have a permit. Normally gives 2 halcyon the night before and 2 the morning of. What is the limit for people without an oral sedation license? Can I prescribe that? Those are the questions that I get. So I'm just putting that out there with kind of goes hand in hand with the stuff that you're talking about, I think. But anyway, just so you know, those questions come quite often.
Thank you, Lee. Well stated and perfect timing as well. Ms. Nichols, do you need anything further on that motion?
Good.
And so you're going to create either virtual or in-person stakeholder. We're going to let the agency decide what they would like to do on that.
How soon would you like to see something like this put together? Within the next month or 2?
I would like to have it so we could be prepared to talk about it at our next committee meeting before the December meeting, unless we want to have 2, one a rule writing after the stakeholder and then another, so we can see how the stakeholder comments come, and we could maybe post that and circulate it to the committee or to me, and then we can determine if we need to have an anesthesia meeting before the next.
You want a stakeholder next, Dr. Henderson, is that?
Do what?
You want a stakeholder meeting next, or you want us to?
Stakeholder meeting next, I think, to get information to help us determine what, if and when we need to write rules.
Okay. That's the direction we need.
Yes, thank you. Okay, next on the agenda, Lee, you get to speak complete on the quarterly update and anesthesia permits, or Ms. Are you going to do this?
We will let Mr. Landon do it.
Good, thank you.
Thanks, Dr. Henderson. This is Lee Lannon, anesthesia specialist. So currently at this time, we have 3,010 level 2 through 4 permit holders. We have worked to date since October 2018, 2,407 of them, which leaves us right now about a sum of about 603, I think. And then on average per year, so between now and our 1 September 2022, on average per year, we're gaining about 190 newbies. So between now and then about 400. So that gives us about 1,000 to work between November. We're booked out, we're scheduled through November, just so you know, between November 2020 through August 2022. So and I'm going to do that. I'm going to say this based on the fact that we're doing about 60 per month or so. That's going to leave us. We have 3 inspectors, and between now and then, that leaves us about a 4-month cushion, I guess you will, at the end of the amount of permits to get completed before the due date. Before, we've always had maybe about 10 months left over, but due to COVID, due to hurricanes, due to reschedules due to COVID, due to we've lost a permit or a inspector. So our timeline, our cushion, if you will, has started to go away. So.
Thank you, Lee. Committee members, do you have any questions for Lee?
Good job.
I want to, yes, I agree. I thought it was getting closer when I looked at the numbers as well, when I was seeing the number of cases you were doing. I wanted to make sure, and we're going to more than meet our deadline for 313, which is really nice. And I want to commend you and Christine for getting all this going very smoothly over the years. And I did have a question on the number of cases that have yet to be resolved on your report. Are some of those numbers going to be cleaned up pending the vote tomorrow on a lot of those dismissal cases that are tier 2 or permit people who gave up their permits?
That could be some of them, yes.
I didn't know if those numbers were already in your report or if those were.
So I want to, just for clarification, you're referencing the ones that have tier 2 inspections out there?
Well, not necessarily, but it might have also been people that were scheduled for an inspection and then they realized they didn't fill out the form properly, and we're in a complaint issue, and we're going to hopefully resolve those. I didn't know where those cases are in your report. I'm hoping it's
So-
where I think it is. It's still showing, and once we vote on that, it's going to dramatically change those numbers. But I don't want to say that if they've already been removed.
So they're still lingering in there. If you look at the tier 2 inspections, those are some of those I'm pretty sure that you're referencing. And your vote or whatever happens tomorrow, yes, that could change some of the dynamics of it. I know some of those individuals have met with IFCs, and the IFC recommendation has come back to go re-inspect a tier 2 inspection, which all of those are scheduled that came back from prior RXCs. So they're being worked definitely. And so will those ones that I think you're referencing right now.
Okay, thank you.
Sure.
Answers the question, what I anticipate. Thank you. Thank you, Lee.
Yes,
Do we
sir.
have any comments from the committee? Seeing none? Do we have a motion to adjourn?
So moved.
Dr. Yu, second by Dr. McNeil. All in favor, raise your hand. And it is unanimous. Thank you, committee, for good work. Thank you, Ms.
Thank you.
Dale. We'll
Thank
see you all later.
All right. Thank you, committee.
One more.
Bye.
Got one more.
314? 313.
All right, everyone can unmute themselves and we are unmuted.
Okay, Dr. Burke, whenever you're ready, we can get started. Can you hear us?
Yes.
We did get notification that Ms. Jones isn't feeling well and Ms. Sisk had a prior engagement, but thankfully with Dr. Tillman's appearance here today, we will have a quorum to have our committee meeting.
Okay, great. Alrighty, so the September 10th, 2020 continuing education meeting of the Texas State Board of Dental Examiners will now come to order. The time is 3:31. A couple of reminders: if you're listening to the meeting on a secondary device, such as a computer or a tablet, please mute it until it is your turn to speak. And this is just in an attempt to prevent any unnecessary background noise or feedback. Also, during the voting process, we will say your name to ensure a proper count. At this time, I'll read the mission statement for the Texas State Board of Dental Examiners. The mission of the Texas State Board of Dental Examiners is to protect the public health and safety and promote high quality and safe dental care by providing enforcement, licensing, peer assistance, and related information services to licensees and their patients. At this time, Ms. Nichols, will you call roll to ensure that we have a quorum?
Yes.
I can do it.
Dr. David Tillman?
Here.
Ms. Catherine Sisk? She is absent. Dr. George Kirsch?
Present.
Ms. Lori Jones? Also absent. Dr. Linda Burke?
Present. We
do have a quorum to proceed with our committee meeting.
Okay, thank you. So now moving on to agenda item number 3, I am gonna also once again ask for Ms. Nichols' assistance in talking about the additional opioid and controlled substance continuing education requirements that we have.
Thank you, Dr. Burke. So these two rules went into effect on September 1st, and they both came out of House bills during the last legislative session. And the board, and I know some board members have expressed confusion and some frustration about the number of hours and the seemingly repetitious nature of the CEs required from both of these rules. So I'd like to briefly go over a breakdown of 111.1 and 104.1 and a course of action that the board would like to take internally to simplify this process for our licensees. So 111.1 is for all DEA permit holders. They must take 2 hours of controlled substances, opioid prescription practices, or pharmacology if you are before September 1st of 2020. So obviously that deadline has already passed. After 9/1 of 2020, new DEA permit holders must take those 2 hours within the first year of obtaining their permit. And for everyone else who is during the course of their renewal period right now, that course must be taken by 9/1 of 2021. So this is an initial requirement only has to be taken once. Get those 2 hours done, get them finished, and you're done. Under 104.1, this relates to opioids. This is 4 hours per biannual renewal, so basically 2 hours per year. This applies to all dentists to provide direct patient care, regardless of whether you have a DEA permit or not. And that's on safe and effective pain management related to opioids and other controlled substances. And those 4 hours will be applied to the 16 hours of required technical and scientific requirements. So what board staff has discussed, our plan, is that we understand this. A lot of our licensees and stakeholders were frustrated about the number of CEs they had to take that, again, seemed repetitious. So what we have proposed that we'll do is once the licensee takes those 2 hours as required by 111.1, we will count them towards the 4 hours required in 104.1. And again, what you still have to meet the requirements and take the 2 hours as required through 111.1. But again, board staff will count those 2 hours towards the 4 hours required pursuant to 104.1. I'm sure there's going to be some questions about that, but essentially what that means for a licensee is they won't have to take 6 hours. They'll just have to take 4 hours, but of those 4 hours, 2 of them need to be the required controlled substance CE as required through 111.1.
Casey, once those 2 hours have been taken, I took mine in 2018. So I'll never have to take those hours again. I just have to take 4 hours from here on out. Is that correct?
You're done. Now you're done.
Okay.
You can take them again if you want to.
Right.
But you're not required to.
Okay.
Towards maintenance, right?
That's right. They count towards record keeping.
So you could take it again and just let it count towards your 4 hours.
Exactly.
Okay. Okay.
So this doesn't require a committee vote. This doesn't require any committee action necessarily. This is just a platform to make this announcement to kind of clear up this situation because, like I said, board staff has received a lot of questions and comments about these rules, and we just want to try to clear this up and make it as simple as possible for our licensees.
Do you feel we need to run it past the governor?
No.
Okay, that's fine. I just don't want to get in trouble.
Well, thank you. Thank you for working on that to our staff, for rolling that together, because that's going to really make things simple for everyone.
And let me just qualify my no by saying that we're not, our licensees are still required to take these hours. So we're not saying, oh, it's fine, you don't have to take them.
Right.
So.
Right. That's correct. Any other further discussion? Okay, if not, we're going to move on to agenda item number 4. And
point of order. That's an internal item that doesn't need a board vote or committee.
That's correct. I just put the agenda for a discussion point so that I could make the announcement in a public forum.
Perfect. Thank you.
Okay, so moving on to agenda item number 4. This is going to involve, once again, 104.1, but dealing more with House Bill 2059 and the requirements that we now have. So once again, I'm going to refer to Ms. Nichols to explain this as well.
Okay, thank you, Dr. Burke. So I'm going to turn this over to Ms. Studdard.
Committee members, staff's proposed rule 104.1 is in your materials, and the applicable portion is highlighted for you. The proposed rule is necessary to implement the requirements of House Bill 2059 of 86 Texas Legislature and the Texas Occupations Code, Chapter 116, requiring human trafficking prevention training for healthcare practitioners prior to the renewal of a license. Details on how to register for the course are currently posted on the board's website. I am happy to answer any questions you may have.
You know, the registration process is horrific. I tried to register. I know Brian Henderson finally registered. It took him 50 minutes to register. I tried the other day and something went down on the website. It's very, are they going to make it a little bit easier for the doctors and clinicians and nurses to register and take this course?
So I think the issue is that there was that September 1st, 2020, when this went into effect. And so it made everybody rush to the website.
Right.
So this is HHSC's baby. This is their project. And but surely if our licensees are having difficulty, we'd be happy to reach out and let them know that our licensees are having trouble taking their course.
That'd be great. It's not the taking of the course, it's the registration before you can take the course.
Right. And I'm sure they've received complaints because this requirement applies to a multitude of different licensees.
That's right. It's healthcare professionals in general. Yes. Right. Yep.
Alrighty. Ms. Nichols, does this require a vote?
Yes.
Okay. So if there's no further discussion, do I hear a motion to approve the board staff's recommendation on Rule 104.1 relating to House Bill 2059 and human trafficking?
So moved.
We have a motion by Dr. Kirsch,
Second
by Dr. Tillman. All in favor? Can we just show our hands there? So it passes unanimously. Is that okay, Ms. Nichols, if we don't call roll by name since there's only 3 of us?
Yes, that's fine.
Okay, thank you. So the motion passes unanimously, and now we're going to move on to item number 5. And item number 5, once again, is dealing, it's Rule 114.12, which once again relates back to the dental assistance portion of the human trafficking rule. And I will defer to Ms. Nichols and Ms. Studdard.
Thank you, Dr. Burke. Yes, it's essentially the same requirements for dentists as dentists and hygienists. This rule is specifically for registered dental assistants, and you'll see the applicable portion of the rule highlighted in your materials.
Okay, wonderful. Do we have any questions, or is there any discussion from Dr. Kirsch or Dr. Tillman? No?
I make a motion to accept.
Okay, so we have, okay, a motion by Dr. Kirsch and a second by Dr. Tillman. All in favor, please show raise of hands. Okay, so that motion passes unanimously. And I don't believe we have public comments, Ms. Nichols.
That's correct. We don't have
We
any.
don't have any public comments and any announcements. So hearing none, do I hear a motion to adjourn?
So
Can I wait? Can I make a quick? This is just a general question. I got an email today from one of our doctors here in Houston, and his assistant RDA is trying to come up for license renewal. She has not been able to take her CPR because of COVID. So the board is not allowing her to renew her license. He wanted to know what we're doing as a board to accommodate this situation, which, mine is going to expire come February. Hopefully COVID won't be as big as a problem as it is right now. So what are we doing to, just as a question, as far as CPR goes, because, we can't, it's hands-on. It can't be a course. What are we doing to accommodate these dentists? Go ahead, Dr. Tillman.
I took it during the break, and the American Heart Association has modified some things to make that to where you can pass it without being present.
Without demonstrating on a.
Correct.
That's my understanding as well.
And so we passed it all. So maybe they just need to be advised to continue looking, call the American Heart Association or fire officer, or whoever they typically get their CPR from.
Right, there are courses available.
Without having to demonstrate that you're doing it. Okay, I will reach out to that dentist and let him know that. Thank you all very much for the update.
Okay, wonderful.
Now make a motion to adjourn.
Okay, great. And a second, Dr. Tillman?
No, I'm not going to second.
We're gonna be stuck. We'll be stuck here. But that was a great meeting. Thank you so much, staff, for all your hard work, because I know you had to work a lot on this and it was quite confusing. I was one of the ones that was confused. And so will we be sure to put something out for our stakeholders to make it easy to understand?
Yes, we'll be sure to do that.
Thank you. Thank you.
Thank you, Dr. Burke. Thank you, staff.
Great job,
Appreciate
everyone.
it. Thank you, Dr. Tillman, for being up there and being in all those meetings today.
Yes, thanks, Dr. Tillman.
We'll see y'all tomorrow at 8:30.
Yes, y'all rest. Y'all rest.
All right, guys.
Bye.
Bye-bye.
Are we calling it 3:44?
3:44, yeah.
Correct.